Good evening and welcome to the Health and Adult Social Care Overview and Scrutiny Committee this Monday the 30th of November. My name is Councillor LJ Evans and I'm Vice Chair of the committee. Firstly, I will ask the Democratic Services Officer to read out the housekeeping notices, please.
Yes, thank you, Chair. So good evening, members, officers and anyone watching the live stream. I'll just briefly run through the housekeeping notice. So this is a formal Microsoft Teams meeting of the Health and Adult Social Care Overview and Scrutiny Committee. Please note that this meeting is being recorded by the Council for live and subsequent broadcasts, and it will be published on the Council's website for a minimum of 6 months. In order to ensure the meeting is managed effectively, please could everyone present follow these ground rules for speaking. So please only speak when invited to by the chair. State your name before you speak if you have not been introduced already, because some people may need to dial into the meeting by telephone and will therefore not have the benefit of the visuals. Please mute your microphone when you are not talking. If you would like to speak at any point during the meeting, please use the raise hand function. After making your point or asking your question, please use the same raise hand function, click it again and it will lower your hand. Please do not use the chat bar for any reason. This can be seen by all parties present. And finally, please ensure any background noise is kept to a minimum as far as possible and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair.
Thank you, Joe. I'd now like to ask everyone to introduce themselves. So when I call out your name, if you could just turn on your camera, say hello and explain your role. So I'll go through the committee members first. Firstly, we've got Councillor Lawrence Fear, who's substituting for Cheryl Johnson.
Hello, I'm Councillor Lawrence Fear and I'm substituting for Cheryl Johnson. I look forward to having my first meeting on this committee meeting of BCP Council. Thank you.
Thank you. Councillor Diana Butler.
Hello, I'm Councillor Diana Butler. I'm in the Creekmore ward in Poole and I'm one of the committee members for this meeting. Thank you.
Thank you. Councillor Jackie Edwards.
Good evening, I'm Councillor Jackie Edwards from Redhill and Northbourne and I'm a committee member of this Health and Adult Social Care Scrutiny Board.
Thank you. Councillor Kieran Wilson.
Yep, Councillor Kieran Wilson, independent councillor for Musgrave and Stratton Park.
Thank you. Councillor Chris Matthews.
Hi, yes, I'm Councillor Chris Matthews. I'm one of the members for Camford Heath in Poole.
Thank you. Councillor Mark Robson.
Good evening, I'm Councillor Mark Robson, Newtown Hellands, and I'm a committee member.
Thank you. Councillor Roberto Rocca.
Good evening, my name is Roberto Rock. I'm a councillor for East Cliff and Springboard and a member of this committee.
Thank you. Councillor Susan Phillips.
Sorry. Good evening, everybody. Newly asked to be on the committee. I have done previous health committees and I am looking forward really to working with everybody and thank you for asking. I don't know where that came from, I'm sure I do, but there we are. And what is down in Winton West is my ward. Thank you.
Thank you, Susan. Councillor Andy Jones.
Good evening, my name is Councillor Andy Jones, Boscombe East and Folkestone Ward, and this is my first meeting in the health panel. I'm very much looking forward to it.
Thank you. And Councillor Dwayne Farr.
Hello, I'm Kinston Ward representative and I'm new to this panel. Looking forward to it. Thank you.
Thank you. And our final committee member is Louise Bate. Are you there, Louise?
Doesn't look like she's in at the moment, Chair, but we'll certainly try and make contact to bring her into the meeting. Thank you.
So Louise joins us from Health Watch Dorset. So we shall now move on to the portfolio holders. Councillor Karen Rampton.
Hi, Karen Rampton, portfolio holder for adult health and social care.
Thank you. And Councillor Nicola Green.
And there I was, apologising for having to switch off my video and hadn't turned my volume on. Apologies to all members. Good evening, everyone. I'm Nicola Green and I'm the Cabinet Member for COVID Resilience, Public Health and Education. And clearly it's the public health angle for which I'm here tonight.
Thank you, Councillor. Moving on to our officers, we have Jan Thurgood.
Good evening, I'm Jan Thurgood and I'm the Corporate Director for Adult Social Care.
Thank you. David Vitti.
Good evening, I'm David Vitti, the Director for Adult Social Care Services.
Thank you. Phil Hornsby.
Good evening, Phil Hornsby, excuse me, Director for Adult Social Care Commissioning.
Thank you. Sam Crowe.
Good evening, everybody. I'm Sam Crowe, Director of Public Health for BCP and Dorset Councils.
Thank you. Elaine Stratman.
Sorry, apologies, Chair. Elaine won't be with us today for personal reasons.
No problem. Thank you for letting me know. And Joe Tyler.
Thank you, Chair. Yep, I'm Joe Tyler, Democratic and Overview and Scrutiny Officer, and I will be clerking the meeting this evening. Thank you.
Brilliant, thank you. So the remaining guests, I will ask them to introduce themselves when we move on to the relevant items, if that's okay. So we'll now move on to the agenda items for this meeting. Oh, apologies, I believe Councillor O'Neill has just arrived and would like to say hello as well.
Good evening, Councillor Tony O'Neill, Penhill Ward, standing in for Stephen Bartlett.
Thank you very much. Lovely. So firstly, we'll hear the apologies. Over to you, Joe.
Yes, thank you, Chair. So as we've already heard, for item 1, apologies. We've received apologies from Councillor Cheryl Johnson, and subsequently we have Councillor Lawrence Fear substituting for this meeting in place of Cheryl Johnson. I'll hand back to you for item 3. Thank you.
Brilliant, thank you. So item 3 is the election of the chair of our committee. So I will seek nominations for the position of chair of this committee for the remainder of the 2021 municipal year. Please note that if there is more than one nomination, the matter will need to be resolved by way of a secret ballot, and the meeting will be adjourned while the secret ballot is conducted. So opening the floor to nominations, please.
Chair, I'd like to nominate Councillor Jackie Edwards for chair.
Sorry, I didn't see who was speaking.
Yeah, apologies, Councillor Andy Jones. I'd like to nominate Councillor Jackie Edwards for chair.
Thank you very much. And do you have a seconder?
Yes, Councillor Lawrence Fear. I'd like to second Councillor Jackie Edwards. Thank you.
Thank you. And I have a hand raised for Matthews.
Yeah, thank you, Chair. I'd actually like to nominate yourself, Councillor LJ Evans, as chair for this committee.
Thank you. And do you have a seconder? Kieran Wilson, you have your hand raised.
Sorry, I was on mute, Chair. Yes, I'm more than happy to second that.
Thank you. Would anyone like to speak in support of the nominations, either the proposer, seconder, or the person nominated? Please raise your hand if you'd like to do so. Councillor Susan Phillips.
I do believe that Jackie Edwards, having sat with her for 4 years on this committee, that her provision and the time she gave during the daytime to that subject matter was second to none, and I couldn't have dedicated as much time as she did. And I believe she will be, for me, the best person. Thank you.
Thank you, Susan. Councillor Phillips and Councillor Matthews, your hand is raised.
Thank you, Chair. I'd like to, well, obviously I've nominated you as Chair, and I really feel that you are the right person for the job. You have a wealth of experience working within the acute and non-acute sector as a GP. I think you've got a wealth of experience as a family carer. You've been the Vice Chair of this committee since its inception, and so I fully support you, and I'd just like to just say that really.
Thank you, Councillor Matthews. Would anyone else like to speak at the moment? Okay, no more raised hands. So I shall now pass over to the Democratic Services Officer to explain how we will now undertake the secret ballot.
Yes, thank you, Chair. So because obviously we've got a contested election of chair, and we'll go to a secret ballot. We will be halting the live stream for this and just adjourning for the time that this is being conducted. So the live stream will be paused, and then once the secret ballot has all been cast and finalised, we'll come back and I'll welcome everyone back and reveal the results of the secret ballot. Thank you, Chair.
Thank you. Can I just check if Councillor Fear wanted to say something? I've got a raised hand notification.
Yes, thank you. I would just like to just reiterate what's already been said in regards to Councillor Jackie Edwards. I think she'll make a great chair of this board, as I've worked with her on previous health boards under Bournemouth Council. She was spectacular in that role, and I believe she will do a fantastic job. Thank you.
Thank you. So Welcome back, everyone. I apologise for the lengthy delay. Unfortunately, there were some technical issues with the electronic voting system, but these have now been resolved, and I'll pass over to our Democratic Services Officer to announce the result.
Yes, thank you, Chair. So the result of the secret ballot for the election of chairman is as follows. The total number of votes cast for Councillor LJ Evans was 5, and the total number of votes cast for Councillor Jackie Edwards is 6. Therefore, Councillor Jackie Edwards is duly elected chairman of the committee. We may just need to take a few moments to sort of hand over to Councillor Edwards and on the technical side, but I'll hand over now to Chairman Councillor Edwards. Thank you.
May I please comment that I followed every instruction I was given, Councillor Evans, absolutely everyone. Perfect on my side of the situation, and I've done this not many times, but quite a few times before without a problem, so I apologise, but I followed all the instructions. Okay. There we are.
Thank you, Councillor Phillips. Joe, so can I just ask, are we voting for a vice chair, or is Councillor Evans staying in position as vice chair?
No, Councillor LJ Evans is the vice chairman for the remainder of the municipal year, as per a previous vote in a previous meeting. So no, that's the case. Thank you, Chairman.
Yeah, thank you for that. So are we going back to the agenda now? I will excuse myself at the moment. If I turn my head, it's just that I've got my agenda on my desktop computer. So if you see me turning sideways, that's what I'm doing. I'm looking at the agenda. So if we can go to item 4, that's declarations of interest. Have any committee members any declarations of interest, please? Can you indicate by using the raised hand feature? Thank you. Councillor Evans.
Thank you. First off, may I offer my heartiest congratulations on your new role, and I look forward to working with you.
Thank you. Yeah.
2 declarations of interest for this meeting. Firstly, I'm a bank employee of the University Hospitals Dorset Foundation Trust. Secondly, with regarding item 9, the report on Tricuro, until last Thursday, I was on the Tricuro Executive Shareholders Group. Unfortunately, I was then informed my services are no longer required. However, on the advice of the monitoring officer, I shall withdraw from scrutinising their report.
Thank you, Councillor Evans. Joe, I'm a member of the Tricuro Executive Group, so I won't be commenting on agenda item 9 either. Thank you. Is there anybody else? I can't. Oh, Councillor Matthews.
Thanks, Chair. I'd also like to congratulate you on your election as chair for the committee. Yeah, I'd just like to declare an interest as a governor of Dorset Healthcare University NHS Foundation Trust. Thank you.
Thank you. I can't see any more raised hands. So can we go on to agenda item 5, confirmation of minutes from the meeting held on the 28th of September. Unless anyone indicates otherwise, I assume the committee agrees to confirm the minutes from this meeting are true. Councillor Robson.
Yeah, I don't dispute the minutes, but I'd just like to have another look at paragraph 88, and just needs a little bit of tidying up on the minutes point of view. And just, I think, on the layout of those minutes for next time, please, can we just, there's an awful lot of text following paragraph 88. It just needs to be broken down so it's a bit easier on the eye, please.
Okay, noted. Thank you, Councillor Robson. So we'll take that as read then. Thank you, Joe. Right, moving on. Sorry, was there someone else?
I was just saying no, thank you, Chair. I've noted the comments made by Councillor Robson, so thank you.
Okay, thank you. Can we move on to item 6. Do we have any public issues, Joe, for this meeting?
No, there are no public issues for this meeting. Thank you, Chair.
Thank you. Moving quickly on to item 7, the action sheet. Unless anyone indicates otherwise, I assume the committee agrees to note the action sheet which tracks decisions, actions and outcomes arising from previous committee meetings. Councillor Diana Butler.
Yes, just to check with you, Chair, item on the big plan 59, it was actually taken to full council, the People First Bill of Rights, and we actually voted on the motion and passed the motion. Whether that has to be updated on the action plan, I'm not sure. That was on the 24th of November.
Thank you, Joe. Did you wish to comment on that?
Thanks, Chair. And yes, Councillor Butler is quite right that that item was considered by full council, and the Bill of Rights Charter was approved and to be upheld by full council. At the time that the action sheet was published with the agenda for this meeting, we hadn't actually had full council, but so it's just the action just explains the steps that had been taken. But yeah, you're quite right, Councillor Butler. Since then, full council has approved that, so that can be added to the action sheet for next time. Thank you.
Thank you.
Thank you, Councillor Butler. Thank you, Joe. Has anybody else got any questions? Oh, Councillor Robson.
Yes, thank you. I know we passed this at full council. Just look at good piece of work. Just like make a note though that in there we did say that everybody has the right to learn to drive. I know this sounds a bit picky, maybe, but I don't think that really should be the case for anybody, whether you're disadvantaged or not. It's a privilege to be able to drive. I don't think it really should have been in there. Apologies for not raising that earlier, but I'll just make a note of that now, please.
Thank you. Noted. Anybody else? No. Can we move on to agenda item 8, the NHS COVID-19 winter response? I'd like to welcome our colleagues in the NHS and the CCG to present the item. Members, if you have a question following the presentation, could you please use the raising hand function? Thank you. So if our colleagues from the NHS and CCG could say their names before they speak, that would be very helpful for those listening in. Thank you.
Hello everyone. So I'm Tim Goodson. I'm the Chief Officer for the CCG and lead for the Dorset Integrated Care System. I think we're going to do this as a double act with Sam Crowe, the Director of Public Health. I see Sam's hand's gone up. I just wonder whether we're going to start with Sam's presentation.
Thanks, Tim. Yeah, I was just going to point out, Chair, that I'm going to just preface the NHS presentation with a current overview of the situation with COVID-19 and what we've been doing across the system to help prepare for winter.
Thank you, Sam. Would you like to sort of go ahead with that?
Yes. So I'll just share my screen. Hopefully this won't be too painful. Just waiting for this to come up. Hopefully you'll be able to see the slides in a minute. And then what I'm going to show hopefully gives members some context to follow when we start to look at the response of the NHS. So I guess my first message tonight is that lockdown, as much as we don't like it, has been remarkably effective at bringing the cases down. So a couple of weeks ago, I was very concerned as Director of Public Health at the rate at which our cases were going up. Current information that we've received this morning shows that the 7-day case rate per 100,000 population is currently at 94 cases in BCP Council, and it's down to 81 cases per 100,000 in the over 60s, which is a completely different situation. So just 2 weeks ago, we were touching 250 cases per 100,000, and all of the indicators were heading in the wrong direction. So that really has been quite a dramatic turnaround. In terms of our testing, current capability is very good. Our capacity is very good. We're testing nearly 10,000 people per week in BCP Council. That hasn't changed particularly since we noticed a huge improvement in our capacity. One of the metrics that's considered in terms of our current situation is the proportion of people testing positive, particularly in the community testing pillar. That's pillar 2. That nearly reached 9% in BCP Council a couple of weeks ago and is only just starting to come down. So it's currently 4.5%, and we monitor that very carefully, but it's really encouraging that that is coming down. But I guess we can't be too cautious, and my assessment as Director of Public Health is that the previous restrictions when we were in Tier 1 certainly weren't able to limit the rise of infections, and hence that underpinned the national decision to look at where we will exit on the 2nd of December. I'll come back to discussion at the end of the presentation of those measures. But I just wanted to show members this curve because I think this sets out fairly well in plain sight exactly what we've been going through. As you can see, the escalation when we started to notice that steep increase in infection rates was really, really dramatic, partly fueled by summer travel, but also the return of schools. We had a second step up coinciding with the return of students, although by no means was it all to do with the return of students. And then this kind of continued climb up until mid-November, and since then you can see since the 5th of November measures were imposed, we've started to see the cases dropping off dramatically, which is really, really welcome news. Just a few notes on preparing for winter, as that's the theme of tonight's presentation. We've been running 2 local outbreak management plans across both unitary councils, Dorset Council as well, and the public health team has focused on supporting the response to COVID affecting complex settings. So the team very much work alongside council and NHS colleagues to provide infection prevention and control advice, carry out risk assessments, and make sure that the right things are being done to contain and limit the spread of COVID. We've provided an on-call consultant service which provides 24/7 advice as part of that response. We have a day duty desk that handle the incidents and the issues coming into the team, and Epicel, which is a collaboration not just of but of other organisations' intelligence leads, has been producing a range of reports, not just the Epicel briefing, which goes out once a week, but also near-term forecasts, which look at our local modelling of what we expect to happen in hospitals, particularly looking at the impact on our hospital capacity. And just to give you a flavour of a typical week, just a week ago, a typical week and around this time of the surge would have involved around 90 separate incidents across both councils. And that would be a mixture of both single positive cases affecting care homes, but also more complicated outbreaks, dealing with the consequences of positives in staff, but also pupils in schools, and a number of workplaces increasingly affected, and increasingly healthcare settings. But because of our strong relationships, the way that we've developed our standard operating procedures, working with council colleagues and the NHS and other partners, has limited the impact of those incidents, but it does take up a lot of our time, and that's where a lot of our efforts currently focused. Looking forwards a little bit to some of the longer term interventions that we badge under what's called the Contain and Enable strategy, we were starting to try to stand up a medium term response, if you like, rather than just being in acute response mode all of the time, looking to develop local contact tracing, trying to integrate more closely with NHS Test and Trace, but above all, working through both councils to follow up people who've tested positive and to try to remove as many barriers to self-isolation as possible, in the knowledge that it's not always effective and that people are not always complying with that. The second wave, I think, started a lot earlier and was more intense than we had predicted, and partly I suspect that may have been driven by some of the national issues around access to testing in the autumn. It's now much more improved, the capability is there, and the testing volume is more than adequate to cope with what's coming through locally. We've got the addition of these new rapid lateral flow tests coming out to sectors at pace as well. So the NHS are receiving their kits. We will shortly start to see the use of those devices in the care sector to support safe visiting. And the universities are also currently using those devices to test students in advance of their travel window. Once cases have fallen, looking at a local contact tracing partnership, as I mentioned, with NHS Test and Trace, as well as other models to try to improve local follow-up. And above all, we'll be undertaking lots more comms and engagement driven by some of the behavioural insights that we've gathered from the pandemic so far. And that's already starting with a focus campaign around young people. Looking at our transmission currently, and particularly what's been going on over the past 2 to 3 weeks, it has been driven by higher infection rates in younger age groups. But it's still the case that most spread is within and between households, and that's why the importance of limiting social contact is absolutely key. So as part of our protection measures, we have to continue to do all we can to protect COVID or prevent COVID from spreading to older age groups. We still have higher infection rates than we would probably like, affecting our older residents, and that's a measure that government is very mindful of when they're assessing the progress that we're making in bringing case rates down. But it also impacts hugely on the hospital sector and also our care sector. So that's why it's so important to continue to observe social distancing, the basic measures, not overly complicating the public health advice, but just remembering that by far the most effective intervention that we have currently is limiting social contact. Obviously, we hope that that's about to change as the vaccines are rolled out progressively to our local groups and starting with the most vulnerable. But until then, the charts that I've shown you have shown you the power of trying to limit social mixing. Why young people? Just a slide that I think shows this fairly dramatically. This is what we call a heat map, showing the different infection rates between the age groups. You may be able to see some of the age bands here, starting from the younger age groups, the 0 to 15s. What we've been seeing has really been driven by the 16 to 29-year-old age group in terms of infection rates. The darker colours there show a 7-day infection rate per 100,000 that exceeded 600 cases per 100,000, very, very similar to some of the prevalence rates that you'll see in the northern areas. But then as you move up the age bands, that does tail off. But the group we're most concerned about is obviously the over 65s, and particularly people living with conditions that make them clinically vulnerable. That's what really drives what's happening in our hospitals and our care sector. So just a final slide from me before I hand over to colleagues from the NHS, just to note that we're exiting on the 2nd of December, and there's a commitment to review the current tiering. Both councils will be in tier 2, but I'd just remind members that there are several measures that will be considered as part of that decision and as part of the ongoing review. So government has tried to be much more consistent in the way that they set out a framework for assessing where local areas should land. And that involves not just our headline rates, but also, as I've mentioned, the infection rates in the over 60s. The rate at which cases are rising or falling, extremely important in trying to assess the trajectory of where we are. The positivity rate, which I've mentioned, which is the proportion of people testing positive in our testing pillars, but also considering local pressure on NHS services, current and projected bed occupancy, and how things are going in the care sector, including looking at the current situation with outbreaks in care homes. And that's really important because when we have a number of homes that might be closed and unable to take new people because of COVID positives, then it limits our ability to perhaps discharge as effectively as we might. And all of this means that we have perhaps a tougher job to do when we're trying to balance how people move around the system and make sure that they're as safe as they can be when we're moving people around in and out of hospital. Just a final thought before I hand over. Sometimes I get the impression that hospitals and other sectors are looked at in isolation, but of course they're not. They're very much part of the community. So what we see happening in terms of hospitals and outbreaks, and indeed in care homes, is very much a reflection of the prevalence of COVID in our community. You know, the people that work in those settings are very much living, and they're members of households. Then unfortunately, COVID does come into those households from time to time, so it can be very, very difficult spread of this virus. So I hope you found the information in the presentation helpful, just for the broader discussion, and I'll hand over to colleagues from the NHS. Thank you very much.
Thank you, Sam. So I'm going to run through a response from the NHS side, and then I'll introduce you to the rest of the NHS team that's here, and we'll take some sort of questions and hopefully provide some assurance and answers to the committee members. Just before I start that, just to say, some of you may have been at the joint scrutiny committee that we held with Dorset Council a few months back. So that was looking really at the NHS's initial response to COVID and some of the stuff that we've done during the wave one sort of period. So what this presentation focuses on more is what the NHS has been referring to as the phase 3. So this is really the recovery stage as we came out of wave one and started to sort of look forward and trying to get services back up and running again. It does slightly predate some of the wave 2 surge that we've seen over sort of recent weeks on that. So it does feel a bit like, 2 steps forward, 1 step back. But I think you're seeing that there's nothing there to give a flavour of the approach that the NHS has taken really to step services back up again. I'm not going to religiously go through every slide on it. Your officers have got a copy of it, so you're welcome to sort of see that and sort of share it around, and we can take sort of questions on any of that after the meeting. I really just want to give a flavour of the thing that's being done, as I think the questions is probably the better way to actually answer some of the points that you may have. So I'll just share the presentation. So hopefully you can see that now. So as I said, phase 3 really is an overview this of returning to somewhere near to normal levels of NHS service, which I should just say from the outset is incredibly difficult to do. It's been a lot easier to close services down in the first wave to deal with stuff as opposed to stepping everything back up again, which requires now the social distancing even within the NHS facilities, all the levels of sort of PPE and putting all the services back on and off and just changing how the NHS has worked. So this has not been an easy process at all. I think what we would say, I think we have made sort of good progress in sort of responding to everything and trying to get the many sort of services up and running again as safely and as quickly as we can. And we want to make full use of the capacity we've had to try and actually focus on some of the patients that have now been waiting quite a long time now for some of their sort of routine sort of care. And we thank everyone's patience in allowing us to do that. Despite our sort of best endeavours, I think it's fair to say, we're not going to achieve all the standards that NHS England and NHS Improvement would want us to do, particularly around some of the elective care stuff. They were ambitious standards to get the recovery back up and going, and you'll see later what some of our projections are on those services. So just before we sort of share some of that, I think it is important to say, we don't want to necessarily just bring back everything the same way as it was. We want to use some of the benefits that have come out of the sort of the COVID period to try and take some of the good changes that we have seen going forward. I mean, particularly some of the use of digital has, really accelerated during this, and how people can actually access the NHS and how we can actually carry out some of the sort of initial consultations. We've seen a huge increase in that, and that's something that we wish to sort of continue. There's been some great work across Dorset, not only within the NHS, but with other partners as well. And it really does feel as everyone did pull together. And we think the more we can sort of take that forward and have a multi sort of teamed approach to stuff, that again is something that we just don't want to lose that. And I thank sort of all of the sort of the key workers as part of that, and particularly some of our sort of council colleagues who have been sort of instrumental in allowing the NHS to actually do what it does and focus on some of the wider care services as well. So in terms of the request to sort of set services back up again, these aren't all of the ones that came down as the sort of the national answers. This isn't Dorset specific. This is across the NHS in England. But it was really looking at, well, what were the areas where we'd seen some of the weights then build up, and can everyone start to focus to bring those back down again? So again, this really just gives you a flavour of some of that. So these are just examples of some of the existing NHS targets that we were asked to focus on. So cancer was one of the big key ones, because we had seen a drop off in terms of some of the referrals coming into cancer. They really did take a nosedive during effectively the first wave, and where we weren't able to do some of the procedures, the backlog sort of built up in that. So there's been a key focus to get those services up and running, and try and get back to the position which we were pre this COVID, before some of the COVID sort of lockdown. Similarly, some of the primary and community care stuff, some of the immunisations and some of the screening programmes. And again, this has been a gradual sort of step up to increase those services. Continuing healthcare was actually frozen in terms of the assessments during the initial wave, and only went live again from the 1st of September. So again, there is a backlog of cases now to work our way through. Similar story, mental health, learning disabilities as well. And we were anticipating that there would have been quite a big surge, in particularly some of the mental health cases after that initial lockdown, which we've not really seen, or it's certainly not been to the extent that some people were reporting in wave one that it could have been. So there has been some good news there, but clearly we don't know what the hidden position is on that, and that may only actually expose itself over a greater period of time than what we've seen so far. A real focus as well on learning disabilities and some of the annual health checks there. It's been a priority across the NHS to try and just increase the amount of health checks we do with sort of learning disability sort of clients, and again that is being pushed right across the NHS. The urgent and emergency care, the flu vaccine has seen real increases this year. We're running roughly 10% ahead of the number of vaccines we've given at this point of the year compared to last year. It's now going to be extended out further as well, with a focus on some of the lower age groups as well. And that really is something we want to get done early, and you'll have seen all the national measures around that, so it doesn't overlap, or as much as possible it doesn't overlap with a possible COVID vaccine. 111 First is something that's going to be rolled out in the new year in Dorset, and that really is a pushing people towards the 111 service, whether it be online or the telephone service, to try and use that to its full potential, and actually start to use it as a booked way into some of the services around some of the A&E departments and some of the GP services. Just to give an idea here as some of the actual national targets, and you'll see on the right the time frame that we were being asked to try to get back to these. So you can see there's a gradual increase there, 70%, 80, 90, 100, even though they're for different areas. Generally, that was the theme that has been sort of running through. And as I said, these targets do predate the second wave that's coming along. As Sam said, the second wave probably came earlier than we thought it was, but these are the targets that were being set. And in terms of the percentages there, it was really just looking at what was the activity levels, i.e. the number of patients you saw last year at this period, and can you get to 70, 80, 90% of that number of patients through those services. So at least you can get up to on a par with last year. So if any backlog isn't building up, you're at least sort of keeping pace with it. So you can see there's a gradual ask to do that. And as mentioned previously, some of the digital technologies, that was set again nationally there. So can you do some of your outpatient appointments via the telephone or video, and it's similar for some of the GP practices as well. To give an idea of where we believe we're going to be at, and this really is sort of the hospital side of things, the acute side. When we submitted our sort of plan, this is a forward look in terms of can we actually deliver those targets, looking right forward to effectively the end of March next year. And you can see we think we can deliver some, and we can exceed on some areas. Others we're closer. So the amber ones there show that we are close to those national targets, but we're not actually delivering them. And we've got a few there which we just think we won't be able to deliver or even get close to the national position. So ordinary spells is really some of the planned procedures. It's the planned elective procedures. there's been a real pressure on the theatres and the amount of throughput that we can actually get through the theatres due to some of the restrictions and some of the bed space that we've sort of taken out as well as part of that. So that gives an initial sort of snapshot. If you were to compare that with some of the other systems across the southwest, they all show a very similar sort of pattern to that. So I don't think we're unusual in terms of that at all. And this is the position. As I said, they were an ambitious set of trajectories to actually get the NHS fully up and running again. But it does show the scale of the challenge to do that. And clearly, if we're not meeting effectively the same level of activity as last year, the concern is that a backlog of patients build up. And even if some of those aren't urgent now, the longer people wait, there is a risk that they move from being a planned procedure to effectively becoming more urgent the longer it goes on. I won't pause this long on this, but this shows really some of the actual specialties in terms of what we think we will be able to deliver, and a lot of that is around some of the diagnostic procedures and some of those procedures that we don't think we'll be able to meet. The one I would draw out there is, because it's slightly hidden at the bottom there, but the 52-week wait position. This is people that already would have waited over 52 weeks for a procedure. Where we paused the elective procedures during the first wave, and again, this is right across the NHS, we did that. Obviously, if you don't operate for a period of 4 or 5 months, everyone waiting their time has just increased by 4 to 5 months. So we think we're going to have over 7,000 people by the end of March next year who would have waited over a year for treatment. Again, that is not unusual across the NHS, because everyone has drifted out. But that is a high number, particularly I would say for effectively that's a Dorset-wide number for the Dorset population, and we are effectively more of an outlier on that than a number of systems on that. So I will just sort of highlight that, because it does show the scale of what is required for us to actually start to reduce that number. Just sort of switching a bit away from some of the acute side of things on the mental health. So a quick look at general practice. So there was a bit of a feeling as general practice actually sort of closed its doors, and I just want to assure everyone that was never the case. It's always been open. They were always there to see patients and continue to see patients face to face, video consultations and telephone consultations throughout. What we did do, we did set up some sites that dealt with people who had symptoms of COVID, and other sites where it was a non-COVID related reason that the patient was calling. So we started to call those hot and cold sites, and a number of the practices sort of set that up with neighbouring practices in their area, just to try to keep some of the isolation going through and actually focus some of the response a bit more. So that has continued. I won't go through all of that. I'll sort of show just some of the numbers here. So if we just sort of focus on sort of the chart there in the middle, that top line shows the pre-COVID position in terms of the actual appointments that we were doing. So in total, 92,000 appointments, roughly between sort of the October to December period in terms of what we were seeing during that period. And as we've started again sort of post-September, we're now actually seeing more patients than we were there in terms of the consultation. So whilst you can see the dip in the middle, which was really throughout that wave one, that now has effectively caught itself up, and we're now each month now we're seeing the same as what we were seeing pre the COVID position, and that actually shows we are seeing more now. And again, in terms of the split between the routine and the urgents, you can see how that changed in the middle of the period. But again, now it is pretty much back to roughly the same split as it was before the COVID sort of position there. As I mentioned earlier, some of the digital solutions that we've used. So eConsult is a way to actually access your GP practice and have a consultation through that route. And previously we were around about 5,000 sort of consultations a month around that, and that's now increased to 25,000. So a massive increase in the use of that. And I think some people have found that a better way to actually access GPs, and some wouldn't have done. Similar with telephone appointments, so we've seen a doubling of the use of the phone to actually talk to GPs. Again, not one system is right for everybody, But I think what we have seen here, that there is now more of a mix in terms of the way to actually access sort of GPs. As I mentioned, there was certainly a dip in terms of the people contacting the NHS during the first wave. So we really did push on a really engagement and a communications campaign saying, you know, the NHS is open. We went with the hashtag Here For You, and we started to push out, particularly through social media channels, just encouraging people that, you know, if you are concerned, if you do think you've got anything serious, please do contact the NHS. It is open and come through. Clearly, during the first wave, you know, a lot of people were concerned about going anywhere, and I think that sort of played through. Whereas hopefully I can give the assurance now through just some of those slides that you can see, you know, the numbers are back up, and things have now sort of started again, and it feels busy now again, and it's always slightly the case, isn't it? We do move slightly in sort of waves in the NHS, and it's felt really busy in the last few weeks. And then it sort of died down a bit, and I'm sure we'll now see a bit of an increase around the Christmas and the New Year period is always incredibly busy for us. We're looking at ahead now, so, you know, sort of really coming up to the winter period, which does create a real challenge for the services, as, you know, you've got the usual winter sort of trips and falls. There could well be, you know, a flu outbreak to run alongside this. Obviously, we've got the COVID outbreak as well, and I don't really want to sort of deal with it this evening, but clearly the NHS has got its eye on whether there is a Brexit deal or no deal in terms of some of the supply chain issues as well. So you have got a real coming together of a number of pressures that could all come across that sort of winter period, particularly that sort of January through to March. So there's been a lot of preparation sort of going into that, and making sure, you know, we can learn the lessons. We'll continue with some of the primary care hot and cold sites to do that, and actually try and focus on the outbreaks as they occur. So just a bit of an overview of some of the things that also sort of went in place. We've now got a home first model, and this is really around sort of discharge and making sure that, you know, we're getting people out of some of the hospital beds in a quick and efficient way. Continue with the hot and cold sites, as I said earlier. The flu plans being really rolled out, and said, you know, that the numbers are up on that. Increasing the number of people that we've got working on the 111 service, and anything we can do with our friends at the Ambulance Trust as well around the options for conveyancing. We're looking to do that. There are now outbreak management plans in place together with yourselves, really, and how we actually deal with some of the outbreaks that go forward, and really trying to manage some of the surges so we can keep the elective care proceeding during any sort of second stroke third surge around this, because we want to keep things as open as we can. Some of the sort of the challenges we will face, I think, as I mentioned, it will really be around sort of that winter period. Will be a difficult period. We can see that already, and particularly, you know, the NHS is not immune from what the rest of the population sees. So, you know, we have seen a number of staff off recovering from COVID. Certainly, those members of staff, particularly in some of the larger household or family households, having to self-isolate if somebody else comes positive from a test or a suspect, you know, everyone there effectively self-isolates in that sort of household. So that impacts on our sort of staffing across the NHS, and we're just down on some of the numbers that we've got in terms of, you know, we've had to reduce some of the beds in some of the hospitals, really just to get the sort of 2 meters social distancing in there, and it takes time to put on the PPE and take it off again, which again impacts on some of the throughput. So all of these things are stuff that we're having to deal with. And I think it's probably fair to say for the first wave, that was during summer. It was a time when the NHS was going into it in a good position, really, in many ways. And obviously the staff were in a normal working position. Obviously going into winter, much more difficult time to deal with this in terms of, on top of normal winter sort of pressures that we see. A lot of staff have been, you know, really quite fatigued sort of going through this, and we've had to reduce some of the capacity that we've got in the services. So it is a more difficult time to go in. I'm going to pause that there, and I'll stop sharing the screen at this point. I'll just sort of ask the team to introduce themselves, and then we're sort of so if I can just ask everyone to say sort of their name and sort of where they're from, and if we start with Chris.
Hello, I'm Kristen Dominy. I'm the Chief Operating Officer and Deputy Chief Executive of Dorset Healthcare.
Thanks, Chris. If we do Debbie, then Paula.
Hi everybody, Debbie Fleming here, Chief Executive for University Hospitals Dorset. Really pleased to be with you this evening.
And good evening, I'm Paula Showbrook. I'm the Chief Nursing Officer and Director of Infection Prevention and Control at University Hospitals Dorset.
Rav, and then Sally.
Hi, my name's Ravan Ramtal. I'm a GP on the governing body member. I also work as a GP at Highcliffe Medical Centre in Christchurch, and thank you for having me this evening.
Good evening, I'm Sally Sancraft. I'm Director of Primary and Community Care in the CCG.
Okay, so I'm happy to sort of pause there, and perhaps we'll try and field as many questions as we can.
Thank you very much, Sam and Tim, for a very comprehensive run through of all what's been happening, and a glimmer of hope, we hope, with the falling numbers of the COVID locally. So perhaps we can take questions for Sam Crowe first. I can see, and Councillor Andy Jones has his hand raised.
Yeah, thank you, Chair. It was more of a question for Tim, so I don't know whether you want me to hang fire on that one.
Has anybody got any questions for Sam? Oh, Councillor Butler, is yours for Sam Crowe?
It was generally about the flu vaccine. I don't know who would like to answer that.
I don't know. Sam, is that with you, or Tim, do you want to take it?
Well, perhaps if you ask the question, and I'll direct it to whoever I think is best placed to respond.
Okay, Councillor Butler.
Thank you. Yeah, it was really just a question of, do you consider if we have an increase in flu vaccine uptake across more ages, it will help people to be more immune to COVID? Because obviously flu is a virus anyway. Would that help the situation this year?
So I'll just look to see if everyone has a medical view on that in the team, but certainly, so I'll probably come to Rav on it. I mean, clearly it wouldn't help if you have both at the same time. So I think that is what we're trying to avoid. But in terms of any actual clinical reason on the actual flu jab itself, Rav, do you want to try that one?
Yeah, hi, Councillor Butler. I think they're different viruses, so you would expect the different vaccines to help protect against each one. However, what it would help here by having both vaccines is if you do have underlying health conditions, I think they will certainly help your immune system protect you against both viruses. But I think one won't offer protection against the other. There are different classes of vaccines, is my understanding.
Thank you. Does that answer your question, Diana?
Oh, sorry, I think that helps. Thank you.
Okay, thank you. I can see there's a hand up, but unfortunately I can't see whose face it's for. Do you want to write in the chat bar RTS? Perhaps that'll help.
Councillor Edwards, it's Joe Tyler here. On my system, I can see Councillor LJ Evans and then Councillor Chris Matthews have their hands up.
Okay, thank you. Councillor Evans, did you want to go first?
Thank you. I think I may have snuck in there, so I apologise, Chris. Questions for Sam Crowe on lockdown. Do you think we've moved out of lockdown too soon? Obviously, there's at least a 2-week time lag from any changes that are made in the community to the infection rates. And on that basis, I'm wondering about why tiers will be reviewed on a 1 weekly basis. Surely we're just making too many decisions too quickly to actually look at the evidence. Finally, will our Christmas plans be affected by whatever tier we happen to be in on the 22nd of December, or is that irrelevant? Thank you, Sam.
Thank you. So whether we come out of lockdown too early, I think it's probably not so much coming out of lockdown too early as where we exit. And obviously there was some disappointment expressed at the decision to place both councils into tier 2. But I think when you look purely from a public health perspective, you can understand why government is being extremely cautious about the way that we unlock. So I think it's probably quite sensible to wait until the 16th of December and to make sure that when we come out in tier 2, that is still sufficient to keep that trajectory moving in a downwards direction. What I personally feel would be really unhelpful is if we exited too quickly on the 2nd of December, get into a situation like tier 1, for example, and then just have to find ourselves going back into that very difficult decision-making situation of having to apply sort of further measures. So I think the rationale seems more consistent. I know that it may not be pleasing everyone necessarily, but you can understand why government is taking this approach. In terms of the weekly review, it doesn't necessarily mean that that will change anything. It just means that the government have committed to being more consistent and transparent about the basis on which the evidence is considered, because I think that was something that was perhaps not communicated as well as it could have been the first time around, and it led to that difficult situation in some of the northern metropolitan areas with a great deal of confusion about exactly what was the basis of the decisions that were being taken. The final part of the question in terms of the arrangements for Christmas, if you're talking about the ability to see household members, so up to 3 household bubbles for a limited number of time, the 5 days trumps everything. So it doesn't matter which tier you're in. The guidance that's been issued for those 5 days around Christmas is in together, but in a way that they feel probably limits the risk as much as possible.
Brilliant, thank you very much.
Councillor Matthews, I think you're next.
Thank you, Chair. I'd really like to congratulate everybody on an excellent report, very thorough. In fact, one of the questions I was going to ask related to the impact of staff absences on the capacity of hospitals to cope with COVID and non-COVID things, but Tim really kind of covered that, so thank you ever so much for that. One of the issues that it's a particular issue I didn't notice that came up in the report was things like access to blood tests, and I know there's been a national issue for the supply chain in terms of the shortage of reagents and so on. So I know there's a real kind of issue with that. But so I've been contacted by quite a few people who've had issues with blood tests as an example, and I'm just kind of wondering, people have been having to wait sort of 6 weeks in some cases, and I'm just kind of wondering what the current situation is with that and whether that's kind of resolved itself, because obviously I know people have had blood tests cancelled for because they've been deemed non sort of emergency and so on, and actually blood tests do tend to show up all sorts of things that people might be dealing with. So that was one particular thing. I don't know if you're able to enlighten me on that at all, but thank you.
Yeah, I'll go across in a minute to Debbie and Paula and give you the position from University Hospitals Dorset as they saw it. But you're right, there was a national issue with the supply chain around some of the reagents, and whilst the suppliers actually got that sorted, it wasn't particularly COVID related, it was a supply issue. We did continue to do all the urgent bloods, but the routine ones then began to back up, and if you leave them long enough, same with the other stuff, the routine then becomes effectively urgent after a period of time. But perhaps Debbie or Paula would like to just run through, because it really impacted on University Hospitals Dorset particularly.
Yeah, thank you. I haven't got the specific position for today, but what I can say is, firstly, I think as a system we did really well working together in Dorset with our GP colleagues as well to make sure that we maintained the urgent work. It wasn't okay, but it wasn't COVID related. So that was, and certainly the supply chain issue, as I understand it, has been resolved, and that people are working to catch up. But we could get more figures on that or confirmation for that separately if that's of interest. I think it was certainly a massive blip, but I think that hopefully that is now being resolved and that fewer people are waiting or impacted.
That's great. Thank you, Chair.
Thank you. Councillor Robson, I believe you're next with your question.
Great, thanks, Chair. Yeah, this is for Sam, I think, about your presentation. I really enjoyed it. Just one on positivity rates. I was just wondering what the weighting on the criteria was as far as, you know, over 60s, under 60s. And throughout this crisis, it has been a communications problem, I think, and the general public, you know, getting behind it. And my real question is about testing and getting enough people tested so that we get a true reflection of what our infection rate is in the area. So that percentage, you know, what to get that percentage down, if you like, so that we get a wider. I'm assuming that with the over 60s, we've got a pretty good idea of where we are at, but the general population, you know, 60 down to 20, people not bothering to test, how are we going to get them into test? I only say that because and this is just a snapshot. I've driven a couple of times now, quite regularly, past the Camford Heath testing station, and it does appear to be empty with nobody waiting. So I was just wondering, you know, can we fast track people through there, or what's our sort of plan and our communication message to get people tested? Thanks.
Thank you, Councillor Robson. I think there's some really important points in your questions there, and I think there's no doubt that nationally testing suffered from the issues of laboratory processing capacity. So at a time when we were trying to advertise the availability of testing, and the testing cells worked brilliantly to bring many more different ways that people can access tests to Dorset and BCP Council, it was unfortunate that we were constrained by that pinch point nationally. But I think I wouldn't be too dismayed by the visual, you know, the look of the testing sites being perhaps emptier than usual, because people can order tests via the online portal. There are other ways that people are being tested that all feed into those results. I guess the only way that we can have a real judgment about the extent to which testing is reaching people is comparing with some of the national prevalence surveys that are being done. So the ONS React 2 seroprevalence survey, which is done regularly. We've been keeping an eye on that to see whether we think that we've got a testing gap locally. Actually, what we saw was when our infection rate started climbing, we were testing more and more people, and a higher proportion of those people coming through Pillar 2 were testing positive. So had that not happened, I think there could have been a danger that we might have been missing people in the community. But it did seem to match and mirror many other areas nationally, showing a very similar pattern when we entered that epidemic phase of transmission. And it's supported by the seroprevalence surveys. So over the past few weeks, we've seen our infection rates rise. That's been supported by the very careful sampling that the Office for National Statistics has done. And the most recent seroprevalence surveys are now also showing those infection rates coming down. So it may not be perfect, but I think by considering all of those parameters, we're reasonably confident that at least you know, a fair proportion of people are coming forward for testing. But you're right, above all, we do need to keep reminding people it's important to get tested, particularly if you have symptoms. And we remain to see what will happen with the greater deployment of some of these rapid antigen tests, because we'll be testing many more areas of the community that perhaps haven't had as much access before, particularly looking for asymptomatic people.
Great, yeah, thanks, Sam. That's great.
Thank you, Sam. Can I just bring in Councillor Green here, who wishes to respond to Councillor Robson? Councillor Green, please.
Thank you, Chairman. Thank you very much for letting me come in. I'm sorry, my video is still not working. I just wanted to come in because I think that that question that Councillor Robson asked was really pertinent. And the crucial words that I wrote down was, are we really getting enough evidence to be sure about that we're getting the true picture locally? And it was something that came up this morning, and one of the things which has been really reassuring about this otherwise awful time is the amount of data which has been available and has been able to be tested and probed. And we asked Sam this morning, following on from a suggestion, I think, nationally, that as case rates appeared to be dropping, was there therefore a drop in the urgency of people feeling that they needed to get a test? Therefore, were we seeing fewer tests taken recently? And it was really reassuring for Sam to come back and give us the information, and it was in the slides, that there were about 9,000 tests reported, and that's pretty much in keeping with what we've been seeing over the past little time. We have, of course, got other opportunities for people to be tested now with the Hawkwood Road mobile testing unit appearing. So just endorse Sam's comment that just because we haven't got the cues that we all saw, and you're quite right to refer to them at the beginning, that there is less difficulty, I think, for a lot of people being able to get hold of the tests. And while we can't ever be absolutely sure of that on an individual basis, looking at those numbers and seeing them consistently hold up really does give a bit of reassurance that the percentage going down in terms of the positivity rate is the right indicator. So thank you to Councillor Robson for raising that issue, and thank you, Chairman.
Great, thanks Nicola for those comments, and thank you, Chair.
Thank you. Councillor Farr, I believe you have a question.
Yes, thank you, Chair. My question was about the 111 service. Presumably with extra demand, well, my question is, if there is extra demand, does this mean there's longer waiting times? Of how, question is, how sort of efficient is it running? Is there extra capacity for that service? Thank you.
Yeah, so I'll go to Chris at Dorset Healthcare to do that. Actually, tell you some of the steps they've been putting in place to actually increase the capacity in the service.
Thank you. So yes is the answer. There has been increased demand, and it is often related to a news article or something that's happened locally within the community. In order for us to be responsive and to make sure that we answer the phone to whoever needs particular advice, we've increased our capacity for 111 call handlers, and we also have a plan in place to deliver the 111 first service, which means that patients who would ordinarily have been going into the emergency departments in the acute trusts receive an intervention at the beginning of their phone call that points them to the right place to go, rather than going to ED to receive the same advice and then to have to go elsewhere. So we will have an additional between 25 and 30 call handlers available to respond to the surge in demand with COVID particularly, but also to be able to respond to 111 calls in relation to diverting them away from EDs. The purpose of the diversion is to make sure that only people who really need that type of intervention go there, so that we can protect the resource that we have available through emergency departments, and also keep patients as safe as possible from any potential infection across the system. So yes, absolutely, we are seeing a surge in demand and we are responding to it.
Thank you.
Thank you. Louise Bate from Health Watch, I believe you want to, is it to ask a question, Louise, or is it an answer to a question?
It was to ask a question. Thank you, Chair. So really I wanted to ask about digital consultations. So I know that there's been a massive increase in the way they're used, and certainly they seem to really suit some people. We've had positive feedback from people about the use of them. We've also heard from a lot of people who find that technology really difficult. So I just wanted to stress the importance that people are offered a choice and support where they need it to be able to use technology. But really my question was about the type of technology that's used. So we were involved in a project in the summer called Doctor Will Zoom You Now, that people from around the country took part in to share their experience of using digital consultations. And that found that most people who'd been able to use a video consultation found it much better than a phone consultation. And people would really prefer that where they're technologically able. So I was just wondering what the plan is to increase the use of video consultations as opposed to phone consultations in the local area.
Did you want to come in, Rab, in terms of your experience as the GP?
Yeah.
And perhaps then we'll go to perhaps Sally for a wider view.
Yeah, thanks, Tim, and thanks, Louise. Yes, I think that you hit the nail on on the head there. I think video consultations, well, there's two varieties we've been using in Dorset at the moment, and they're quite integrated within our System 1 module. We're using a program called AccuRx and AirMid. They're the two video consultations. Now, telephone consultations have also increased, partly because patients don't want to come into the surgery with the current pandemic, and actually it's a lot easier. So we've been using those two digital platforms in Dorset and doing more telephone consultations. Quite a lot of annual reviews can be done over the phone or by video consultation. So one of our highest population at the moment we're finding that have been affected quite during the pandemic has been the learning disability categories, and we've been able to do those by video consultations as well as also mental health consultations as well. Because anxiety levels are quite high. So we've been finding those quite good. Was also, as Tim mentioned earlier, the e-consult, which is now available in every practice going through the website. And it's quite a good fail-safe mechanism when you answer the questions, and you can do that on the weekend. That's opened the door for much more of the younger population. However, as you rightly pointed out, I work in Highcliffe, which has got a slightly older demographics, and it's not always easy for patients with comorbidities. They've got wear and tear of their hands to use iPads and computers, but there's quite often carers or family members that will help facilitate that. And also during this pandemic, it stopped people from becoming socially isolated, being able to contact their surgery on the phone or via a video link. So it has been really good, but mindful from with my GP hat on, it doesn't reduce our workload, it just changes it to a different way. Also, we've also found with my colleagues at secondary care, a lot of the appointments follow-ups have been moving to video consultations as follow-up outpatient appointments, and that's been really helpful for a lot of our patients. So yeah, it's been really good, and we've quite embraced it in Dorset. I hope that helps.
Did you want to add to that at all, Sally? Or...
I would probably just echo Louise's point, and I know the report that you're referring to, Louise. I read it. We need to have a menu of options to support the range of ways in which people can engage with general practice. So I think there's been a really positive response on the whole for access and using technology such as video consults. So we absolutely see that we will be growing that, and that won't be going away. But at the same time, and Tim shared this within the presentation, there will be absolutely an appropriate right time for somebody to need to be seen face to face, and the clinician will all be making that judgment with the patient around managing clinical risk around COVID and their presenting issues. So there needs to be an ongoing menu of options for people to access general practice, which is what we would absolutely endorse.
Can you just check if Debbie or Chris wanted to add anything from their trust views?
Thank you. Just very briefly, Tim, just to say we recently celebrated the fact that we've done 50,000 consultations remotely in this way. Interestingly, so now about probably 34% of our consultations are now virtual. From the feedback that we've had from patients, 95% of patients would be likely to recommend it to others. Though, of course, I think it's important to say those would be the ones who've had it, and obviously people always need support. So we've got quite a lot of information. I think we'll have a mixed economy, won't we, going forwards? We'll always need to provide support for some, and we need to organise our services accordingly. But we also need to see what a fantastic opportunity this is for us to do things better for patients. So yeah, I think we're all very excited by the opportunities.
I think from a Dorset healthcare perspective, there have been different patient groups who have responded well, and some patient groups who haven't responded well. I think we have done some kind of canvassing to find out how people have experienced it. And for certain patient groups, it's difficult and they haven't enjoyed it. For others, it's a confidentiality issue. They don't want to, say, perhaps for children and young people in CAM services, they felt that they didn't want to talk in their family home. So we just need to be learning all the time about what works well and what doesn't work well for our patients, and to constantly adapt and be prepared to kind of change the method of communication with them in order for them to get the care that they need.
Thank you. Actually, if I could just make an observation, because I actually had to do a video chat on behalf of my father this morning with his local GP. He doesn't have a smartphone, so I had to go racing over to take the phone call and the video link, which I have to say was actually quite easy. It was easy. But I did notice it seems to be that these video chats can take quite a long time. So, you know, instead of like a 10-15-minute consultation, I think it could be ending up a 30 to a 40-minute consultation. So that's going to eat into the sort of doctor or the nurse's time there. So I presume that you found that as well. I can see from nodding heads. So, you know, this technology is brilliant and everything, but it is sort of a little bit more time consuming at the moment. It was just a comment I wanted to make there. Councillor Jones, I believe you have a question.
Yeah, thank you, Chair. A lot has been said in recent weeks and months about the effect of the pandemic on NHS staff. I was really pleased to see in the presentation earlier on there was a slide focuses on staff well-being. I just wondered what that actually meant in practical terms, in terms of support actually be given to staff across the service.
Yeah, should we go to Paula on that, seeing as she's one of our nurse directors in the system and has thousands of staff sort of reporting up through her.
Yeah, thank you, Tim. Thank you, Councillor Jones, for the question. So absolutely a major impact in terms of supporting our staff, and that's through a variety of means. I think it's really important that we communicate clearly what's going on. So we have a number of ways of doing that internally in the hospital. That's staff briefings. You may have seen that Debbie, our Chief Executive, has been doing video briefings for staff. And in fact, when we've been doing our briefings, we've been getting up to 500 people dialing in. Another joy of having the electronic way of communicating across our trust, particularly across 3 sites. It's really important. Also, we're doing some very practical things to support staff. So, for example, safe spaces. So that's an area where staff can go, where they can decompress, because if you can imagine working in somewhere like an intensive care, for example, where you have absolutely full PPE and you're dealing with some very complex things. Just having that opportunity to get away and go to a safe space is really important. So we've got safe spaces across our hospital sites. And also things, so simple things like having breaks. We've already heard from Sam about the importance of social distancing. Providing space for our staff to be able to go and have breaks is really important, and it's not as easy in the winter as it was in the summer when people could sit outside together. Also, we really recognise the value of teams. So where we have good, strong clinical teams working together, it means it does protect everyone's resilience as individuals. So looking after those teams working together and really protecting that, but also we have an OD team that's helping that, so the team dynamic work. And finally, we've also got psychologists and then psychological support. So we have experts to be able to support our staff as well. So it's a multifaceted approach. And I think for example, nursing, I have a lot of support from my colleagues across Dorset. So we build really strong networks. And I think out of this, I hope that helps. And thank you for that question.
Thank you, Paula. That's really encouraging.
Thank you. Councillor Slade, have you a question, please?
Councillor Edwards, if I may, I think Councillor Slade may have had to leave the meeting, so she asked me to ask on her behalf, if that's okay.
Yes, that's fine. Thank you, Councillor Evans.
So she's written, I was concerned to read the article written by a nurse at Royal Bournemouth Hospital and sent to the press last weekend, and it raised some concerns. The article strongly suggests that Pillar 1 testing on admission isn't happening by default. What assurance can be given that if someone enters hospital for a planned or emergency non-COVID condition, they will not come into contact with COVID once admitted? and she mentions that she knew of a number of cases where elderly people have gone in for other reasons and sadly died from coronavirus.
Should we go to Paula?
Yeah, thank you. Thank you for that question. And of course, I was really concerned and very, very sad to read the article. One of the things that is really important to me and to Debbie and the board is that staff feel able to raise concerns and are able to do that through a variety of routes, myself included. We have a Freedom Speak Up Guardian who meets with staff anonymously. So there are a number of ways that staff could raise concerns. So it was very upsetting for us to read this. Equally upsetting is some of the detail within the article was incorrect. So in response to this, I had sent out an email to the whole of the trust answering some of those queries. I can absolutely assure you that we do test our patients. So if we think of the routes that patients come into hospital, patients will come in via either an elective route or the emergency route. If your patients are coming in for elective surgery, then they have a test before they come in, and that's really important. So we get the test result and then they will come in for their elective surgery. Patients that come in through an emergency pathway get their test on admission. And what we do is we wait for those results and then we will move that patient. Now, sometimes, as you can imagine, when we have patients that are in our emergency department or in our admissions unit, we do need to move them onto the next stage. So they need to go onto a ward that's more appropriate to their care. What we will do is we'll isolate those patients. So we have very, very strong pathways, and we call those pathways a blue pathway and a green pathway. Sometimes we know when patients come into hospital that they come in with COVID. They may have another condition quite often. So they will go on that specific pathway. And if we don't know, then we will test and then we wait for those results. So it's very clearly defined. We've got what we call action cards, so cards that our staff can access through our internet, because these things have changed very rapidly over the course of the pandemic as we have more knowledge about how the virus spreads. So we do update that. That's on a link that all our staff can access. But it was very disappointing to see that, and very distressing to think that somebody felt that they couldn't come and talk to me about it. And the good thing, I think, in terms of the email that I sent out to staff, then I had a number of queries from members of staff, and that's absolutely fine because we are really keen just to make sure that we're getting the information to everybody that's looking after our patients and doing the absolute best for our patients in these really, really difficult times.
Thank you very much.
Thank you. In fact, I was going to ask something very similar, just so that for the public listening, as to what happens when they're admitted to hospital. So I think that will clear up a few of the questions that they may have. Councillor Wilson, I believe you've got a question.
Yeah, thank you. It was just to follow up on what Paula said there. That was very reassuring. But just in terms of the process of patients being tested, are they tested on site, or are they given a test in the post with a reminder letter of their appointment when they're going through elective surgeries, or how is that kind of administered? And also, how is that then subsequently checked, just to kind of give that extra reassurance to the on-watching public?
Yeah, certainly. So that's a really great question. Thank you for that, because in fact what has been learnt nationally is that the results and when the tests come back positive, there have been some slight changes with when you retest. So what we do is patients come into hospital, and then the process that we were using is test in 5 days. And then, as you will know, when patients are being discharged, particularly to care homes, it's really important that those patients are tested. So they have a swab and we wait for the results and then we discharge to the care home. So that's been a really important pathway for us. Over the last couple of weeks, and in fact, when we saw that we had more cases in University Hospitals Dorset, which absolutely aligned with that epidemiological graph that Sam showed us. So when we saw that increase in October, we saw the same in our hospitals. So we were testing, and what had happened in terms of the learning nationally is that as well as testing day 5, the recommendation then was brought in that we should test day 3. So when we have these things that come through our routes, the communications come through the routes through the Directors of Infection Prevention and Control. So then we're now looking to put the testing on 3 days and then subsequently on 5 days. So things are changing very rapidly, but a lot of it is in response to what we are learning nationally about how this virus works. Thank you.
Thank you. Can I just ask, you did mention something about these shortages of medication and the issues with that, and I have heard various people said to me that they haven't been able to get their normal prescriptions. I just wondered if you could expand a little on that as to what was happening, why people couldn't get their normal prescriptions, and have most of these been resolved now, please?
So I'm not aware of too many. I know there was clearly queues and pressures at some of the pharmacies. Rav, did you want to come in? If you had any experience of any shortage of any of the?
There haven't been any Sorry, thanks, Tim. Sorry, there haven't been any shortages. We have at some stages had to change from particular brands to different generics. So, but we've been able to issue the majority of the medications. Things seem back to normal, almost pre-pandemic in terms of supply at the moment.
Okay, thank you for that. Councillor Wilson.
Hi, sorry again. It was just to follow on from Councillor Edwards' question just then. Obviously, there hasn't been a shortage. Tim touched upon the potential of a Brexit deal or no deal, and I just wondered if there are sufficient contingencies in place, you know, in terms of supply chains and in terms of that process in acquiring PPE and different medicines. You know, what's going on there in terms of reassurance?
I think certainly on the PPE side of stuff, there's so much is now manufactured inside the. There's been a massive change that we've seen during this period. So rather than 95% was coming in from overseas, particularly the Far East, that percentage is now dramatically dropped, and there's been a huge UK increase on it. In terms of the EU exit, obviously we've had one false start of this already. So the NHS has already put in place in terms of all the procedures around that, and effectively there's, in terms of not just prescriptions, but there are, for some of the supplies equipment, huge NHS warehouses, if I call it that, around the country, and we're talking massive scale, and affecting, I think there was 5 and they've increased that to 7 on top of, and they fully stocked all of those. So in terms of the UK being ready, I think the NHS side was very well prepared last time and will be again this time, and put in place effectively direct air flights coming straight in as well for stuff. So particularly in terms of kind of the high volume, low cost, we've got an awful lot of that, and some of the low volume, high cost stuff, direct air flights were being arranged coming straight in. So clearly it is an unknown when it comes to it, and there are bound to be pressure points somewhere in the system. But overall, the NHS feels as confident as it can be, and it was also assigned in terms of priority access through all the ports. So there was different categories, and the NHS was category 1, which actually trumps stuff like food and supplies. So I think the NHS is as confident as it can be. But with these things, it's what you don't know is usually what comes along and trips you up. But that's the risk with anything. But overall, our levels of assurance is good.
That's good to hear. Thank you, Tim. Councillor Evans, I believe you have a question.
Thank you, Chair. Yes, seeing as Councillor Wilson has dared to mention the B word, we've discussed the supply chains, but my concerns are far more over our workforce, NHS, but particularly domiciliary care. And I'd be interested for your comments on that, please.
Yeah, I mean, I suppose we are relying on a lot of overseas people in the NHS, particularly, some of our frontline staff, even on that. So I wouldn't say just domiciliary care. It is across everywhere. And our recruitment now, I would say, isn't just Europe though. We've got people coming in from outside of Europe to do that. So we see much more as a kind of a worldwide sort of recruitment plan around these things. Again, the NHS has tried to accelerate in terms of who can stay and some of the visa stuff and give all that sort of guarantee. So again, I think we're as prepared as we can be. But it remains one of those things where we see, do people leave because they're concerned on it, which is slightly outside of our control. I don't know whether Debbie wishes to come in on that, or Paula, what you've seen at Bournemouth, or even Chris at Dorset Healthcare in terms of position on it.
Well, I mean, in terms of the whole of the Brexit issues and the NHS briefing on Brexit, it's probably quite a big subject in its own right. In terms of, we have traditionally done quite a bit of recruitment from overseas, and we have recently just had another group of overseas nurses come through to us, which it's just so important that we look after those individuals really, really well when they arrive. They may be coming from slightly different places in the past, as you've alluded to, Tim. I mean, generally, we know there's an awful lot of challenges around recruiting workforce for essential workforce gaps in the NHS. The Brexit situation, in fairness, probably hasn't helped that in the short term. People have been working to address those gaps in a whole range of ways. I mean, I don't know, Paul, if you've got anything else particularly to add. Recruitment these are all very big topics, aren't they, in their own right, these things. We could, there's big programmes on how we're trying to address some of our workforce challenges, and they're different depending on the particular group, and we've got a whole range of solutions for fulfilling them. Overseas recruitment is absolutely not the only way in which we're going to be addressing all of the NHS workforce gaps.
I mean, I'd agree, Debbie, and just to add to that, this is one of the strands of work that is also being driven nationally through the Chief Nursing Officer for England, that we are absolutely linked in with. So as well as doing this for University Hospitals Dorset, we're doing it with the work with colleagues across Dorset as well. So really important that we do this as a system, and there are a number of other initiatives that we have in place. So things like the registered nurse degree apprenticeship, for example, lots of different ways that we bring our workforce in, not just relying on the traditional methods of entry into health or social care. And really importantly, and Debbie's already alluded to this, it's about retention. So recruitment is only one part of the story. It's about retaining our staff. And we've already mentioned, it's very difficult working in the NHS in particular at the moment, and the support that we put in for our staff at all levels is critically important, and in all roles.
Thank you for that. Yes, that could be a very big topic indeed. So I think we'll move on from there. Councillor O'Neill, I believe you have a question.
Yes, thank you, Chair. Two questions, really. We mentioned earlier about digital platforms. I'm aware of a practice, a rather large practice of about 5 satellite branches that uses a digital platform. The platform itself won't allow you to submit anything over the weekend, tends to operate during office hours only. Once you find yourself into the platform, it gives you 4 choices. Under each choice, it then does a drop-down menu, and it gets to the point that if you're asking for advice on medication or drugs that you might be on, it won't accept it. So that's a difficulty with platforms. I am finding that a number of constituents are seeking to use online more and more. And the main reason for that is they find it difficult to get past receptionists. And the world's changed with receptionists. One person described it as it used to be 3 really helpful ladies and 1 that wasn't, and it seems to have reversed. Now, receptionists have taken a lot of flack under COVID with people needing to talk or wanting to get to a doctor. I just wonder what support is being given to them, and perhaps some retraining, not just on handling aggravated callers, but also on remembering that the person at the end of the line is a person and a patient. Thank you.
Okay, I think in terms of the digital platform, I think we, if you provide more details on that, I think we'd have to take that one away really, and actually look at what that platform was and the difficulties. I don't think we'd have the expert knowledge in terms of without knowing which platform and which practice to look at that. In terms of receptionists, I'll let perhaps Rav come in and just perhaps share some of his experience from the other side of that, because clearly we do get some difficult patients as well. I would have to say people have become frustrated having to wait and everything. So I'm sure there's two sides to that. What we do is
I did acknowledge that it's about how it's handled, not that it doesn't exist.
Yeah, we do a national, or the NHS does a national survey on sort of GP practices, and that does include sort of the receptionists and the handling of that, and we do overall do really well actually on that. You know, we're one of the best in the country, but clearly some people have different experiences individually. So perhaps Rav, give just an oversight some of your reception duties.
Yes. Thanks, Tim. Thanks, Councillor O'Neill. I think it's been a very challenging time at the moment for our reception team, and overall, I think I'd like to think they do a good job. You are right, there is a patient at the end of this, but pre-COVID, it was a different world on how the reception job was done. They're now having to manage different platforms digitally, which quite a lot of them don't quite truly understand. So there are some training needs across for us to embed within our teams, but there's also at the moment, with the way things are, all practice staff are obviously concerned about COVID. They're all concerned about patients and trying to navigate systems which have changed. We've all very moved overnight from the traditional way of seeing patients, which is face to face, to suddenly much more telephone triage, much more signposting to other services. We've also, during this pandemic, moved to primary care networks, which has also improved our way of working within a network. So there's a lot been going on with our reception teams, and we try to support them as much as we can. I think if there are any individual concerns raised by any patients, I would advise them to link in with their sort of practice manager to look at that. But we do offer, in my own network, lots of training support to our receptionists with the changes that have been going on. I hope that helps.
Okay, thank you very much.
Thank you. Is there anybody else with any more questions on Councillor Jones?
Yeah, thank you, Chair. I wonder if I could ask a question on the Health Watch Dorset report, which was emailed round us a few days ago. Is that okay?
Louise, is that fine with you?
Yeah, I'm happy to talk about it.
Shall we? The others that are on this item, I'm happy for you all to stay, but if you wish to go, that's up to you. I'd like to take the opportunity to thank you for your time tonight, and to also, I'm sure we all wish to give our thanks to all your staff as well through these difficult times. So if Andy, if you want to give Louise your question, please.
Yeah, thank you, Chair. The Health Watch Dorset report states that there have been a number of cases where dentists have levied additional charges on patients to cover the cost of PPE. Given the already fairly significant cost of dental treatments, do we know how widespread this practice is? I'm particularly concerned that this additional cost will prevent some of our communities, so some people in our communities, from being able to afford dental treatment.
Yeah, I totally agree. I think it's a real concern that it could put people off going for treatment that they need. It's not something I have numbers on. We've had a number of people contact us about dentistry, and that's been increasing over the last couple of months. There do seem to be some real issues locally. I've sent our report to the dental commissioning team at NHS England, so I'm hoping to get some answers from them, and I can certainly ask them about numbers around who's being asked to pay for PPE and whether they're gathering feedback as to if that's reducing the number of people accessing treatment.
Do we know whether this is actually confined to a particular practice or a small number of practices, or do we not have that data?
From the people who've contacted us, it's been across the area in BCP and in Dorset, so it hasn't been it hasn't been about one practice, no.
Okay, thank you.
Thank you. Councillor Wilson, have you got a question for Louise?
Yes, yeah. It was just it was a comment and then a question. Just to say that I really like the report. I thought it was really useful and it brought out a lot of, good anecdotal evidence and a lot of insight. My only concern with it was around the kind of who we asked, who we heard from. I think that I think we heard from 12 people under the age of 35, and I think that was around 7% or something like that of the participants. So it's very disproportional in terms of young people. I'm just a bit concerned that we're not hearing the concerns that they're having within healthcare over this period. And obviously, I know that it can probably be hard for to get young people to engage maybe in these questionnaires and things like this. But I was just wondering what we're doing to try and tackle that and what you think should be done going forward. But really good report. Really
Thanks. Thanks, Kieran. I appreciate that. It's a really good point. And I think that this type of online survey isn't the best platform to engage young people. So one of the projects we're working on over the next couple of months actually is we've recruited a youth worker, and we're launching a project in January called Young Listeners, in which we're going to recruit a group of young people who will help us. We'll support them to design an engagement project for next year, so that they'll go out and find the right ways to gather the views of young people for us. Because exactly like you say, this type of formal questionnaire survey just isn't the right route to get young people to take part in things. I hope that helps.
Yeah, that's really useful. Just to follow up on that slightly though, there was still kind of a bit of that kind of under 35, so not quite the young people, but the slightly younger than the next category kind of thing. How would you go about targeting them?
Yeah, you're right. I think we need to look at the way that we send out comms. Actually, we've been looking at the way in which we use our social media, and we know that for that kind of sort of 25 to 50 age group, there are some types of social media that we haven't been using to the best of its ability. So I think it's around the ways that we use to communicate. So we're going to try some more Facebook polls actually over the next few months, which I hope will bring in a lot more people of that age group.
Thank you, really helpful.
Thanks, Kieran.
Thank you, Louise. You might like to send the committee a link for that, Louise, because I should imagine all the councillors on this call have got Facebook and Twitter feeds and everything. And if they can push it out through their social media, that might help your numbers as well.
That would be great. Thank you very much, Chair. Appreciate it.
Has anybody else got any questions for Louise from Health Watch? No? Okay, moving on to item agenda 9. Report on the development and performance of Tricuro, and I'd like to welcome Phil Hornsby and Steve Pink to present the item. I'm not quite sure who's going first, so perhaps Phil, you could introduce Steve Pink to us. Thank you.
I will, Chair. Thank you very much. Steve is the Finance Director for Tricuro. What I thought I would do, I'd just introduce, I provided a covering report, and then I'll hand over to Steve to take us through in more detail the sections of the report that the Managing Director's put together. Unfortunately, Graham Milkin, who's the Interim Managing Director of Tricuro, through personal circumstances, isn't able to join us tonight. But I'm sure Steve will do a sterling job in his stead. So just a little bit of background for members, because there are some new members on the group that perhaps aren't familiar with Tricuro, which was set up as a local authority trading company in 2015 by what was then Borough of Poole, Bournemouth Borough Council and Dorset County Council. And of course, once we became BCP in Dorset Council, the 3 authorities then became 2, and it's now we've got equal shares as BCP in the company as have Dorset Council. And then we have elected members on the executive shareholder group and an equal split between the two councils again. So just wanted to give some context in the sense that we have a set of contractual arrangements with Tricuro as a council, and they're worth just under 18.8 million. There's some detail within the interim managing director's report, which was an appendix to this report. And during that time that we've been trading as a local authority trading company, Tricuro has been able to put forward efficiencies and savings to contribute to the council's medium-term financial plan. And as we get into some of the detail and the modernisation programme within the report, there are some further opportunities whereby Tricuro can add some financial support again to the MTFP. So at that point, I'm just going to hand over to Steve, and we'll be available for questions at the end of the presentation. Thank you.
Thank you, Phil. Good evening, everyone. Firstly, everyone hear me all right? Good. Remember to turn your mic on in this situation. Okay, so apologies that Graham's not with us today. Obviously, this was Graham's report, and much of the detail of it is going to be a little more challenging to answer than if I was Graham in person. But if I take you through the report as it stands and try and embellish on each individual area. So the first part of this is probably the section on the COVID response. Now, Graham actually took up post about a week before the COVID situation became serious within the UK. And we, along with our SLT, started an immediate response before the country had taken its own measures. So we closed our homes to visitors about 2 weeks before the guidance came out to do so. So we preempted the situation as it was going to be, and actually that was really helped on our initial and in the initial circumstances for us. I think by some of those measures that we took, we've been very lucky that our infection rates and unfortunately the death rates within our homes have been significantly lower than they have across the piece in general. On top of that, we also looked at our infection control measures. Again, we were very fortunate that when Tricuro was set up, one of the members of staff who was transferred actually out of Dorset Council was a national policy writer on infection control. So we were very lucky with the personnel we had. And so we already had very, very strict infection control measures for to general sickness outbreaks effectively. So we were able to adapt and change those policies looking at the guidance that was available and bring ourselves up to speed with that very quickly. Obviously, this required a lot of for PPE, as we all know, and the supply chains on those have been very difficult, and there have certainly been certain companies that have been profiteering. And we managed to actually be involved in a couple of supply chains that were giving out the government stocks of those. So we got those at standard prices, so we weren't impacted so much by the inflated prices at the time. And we also then started stockpiling where we could. So to avoid, again, significant price increases, we were stockpiling at one point about £80,000 worth of PPE. So we had created a secure unit to be able to do that, and then a distribution method. So getting all that into place meant that we've had no occasion that I'm aware of where actually any of our services have actually been struggling for the PPE they require to deliver our services in a safe manner. So all of these things that we put together, so it's really helped us, certainly during the first wave, to keep ourselves in check and actually make sure that we've performed probably certainly above the standard expectation. Now, one of the other big issues we to deal with is the lifestyle and the complexities of the people who live within our services. So we then have to look at guidance over visiting and safe spaces and all those other individual things, the complex parts that make up that. So again, what we've looked at is, thankfully, there's been infection control funding that's become available, and it's making sure how we spend that money as well. So some of those can be in creating those safe spaces so that visitors who wish to come to our sites can do, as we came out of the original lockdown, we were able to start bringing certain visitors in by having those specific safe spaces and safe measures in place. So there was access for some of our residents to see their relatives as well. Obviously, we have to measure that with how the national lockdown and the tier systems are working. But again, we have a really good team in place at the moment to monitor all those and to dissect the detail to make sure we're complying in all regards. We're also lucky that we have a registered nurse who is in charge of, a former registered nurse who's in charge of one of our service areas. So we do get we've got we're a really good team who are able to support that and looking at it from both care and medical aspects as well. As I filtered down the report, you'll see that one thing we've done is obviously for consulting with families and clients as well, and we were bringing in technology was another obviously key part to how we can support our services, particularly within the residential homes. So again, we've been looking at how we can do virtual conferencing, virtual phone calls, all those kind of things to be able to keep our clients in contact with their family members and to try and make their stay during the difficult period as comfortable as possible. We're also making sure that our staff are very important to us and that we try and keep their morale high. Now, it's obviously very difficult when you can't go out and visit those. So again, particularly for Graham as a new managing director, to be able to come and not actually go out and visit his services regularly. So on that regard, we started up our Tricuro Cares. So part of that was just a good news story to filter out all the things that were going on and the positive sides of it, but also keep everybody up to date with how the different responses were between different sections of the service. That's actually gone really down well and has been really positively received by the staff and the managers alike within the services. We are quite lucky that actually our staffing complement has not dipped too much, certainly in the residential homes, and we have been able to keep our agency spend at a reasonable level, certainly very slightly higher than we would normally see it, and that part of that is to how we've managed our staffing through the crisis. Now, if I take a look at our example, we obviously have different suites of services. So for those who don't know, as well as our residential services, where we cover in total about 12 homes across the entire Dorset nation, we also have about 25 day services of different sorts, and we have a Ravenwood service, one that covers Dorset and Bournemouth areas at the moment, although not Poole. Now, that means that we've got a completely different staff mix up and a completely different service offer in many ways, and we can actually be flexible across them to be able to deliver our staffing. So whereas the lockdown would have meant that the day services as they were, so any services delivered in day centres to start off with could not be delivered in the COVID secure way, it also meant that we had a staffing group who we were able to redeploy. So by doing so, with staff, obviously we have plenty of staff who were self-isolating, we have plenty of staff who were required to shield, but we had a backfill of staff from those day services, and we were able to then put those into set residential homes, or some cases into the community as well, to be able to help deliver and support our services, thus keeping our staffing measure under control. Now, from that, as been to say, it's been really positive that we've been able to keep our agency costs at only a fraction higher than we would have expected anyway. Now, we've also built up strong networks with the local agency, so when we've had to have staff, we're making sure they're complying with only working in specific homes. So again, all about trying to minimise cross-infection. And I feel we've done that fairly well. And I think what's happened as the second wave has hit is we're very confident in the way things have had, that we've only actually had one positive COVID case, I think, within the services, although we've had about 6 sort of potential ones, but that's within clients. And then as far as staff is concerned, we have at the moment, we only have about a dozen any time staff who are not actually available for work because of either self-isolating or shielding, or who have symptoms. But we've actually had no positive cases within those staff up until I think this week. There was one within our Ravenwood service. Again, we've got some fast testing available to us, so we were able to do that to the team members that they contacted, and thankfully we've isolated that it was only one member of staff. So we're able to respond fairly quickly to the changes that are required, and so far, so keeping everybody, I think, in the service as safe as possible. Now, if we then move on from the COVID situation, so if we want to look at the rest of the report about the current services that we provide, as I say, we've got the 3 particular main service areas. And the residential care, so you'll see in the report here, states that obviously this building-based service, and we have got kind of a lot of our buildings potentially require significant capital investment in them, but those services we're able to be flexible with them as well. So we've got as I said, we've got 20 odd nursing beds within one of our services. We have an intermediate care service at Coastal Lodge. We have the fairly recently transferred over care home for residential service in Fairways, and the 2 mental health services within the BCP area. Now, again, that requires a quite significant different skill set across the group. We are obviously working in partnership at the moment with the commissioners to work out how that stock of buildings and staffing services can be used best to deliver what's required in the future. So we've engaged in a program, a transformation program that was started off in the middle of this year, which we're working through, say, with Phil, his team and other commissioners to make sure that we can look at what's the future needs and requirements of the local authority and the client base, and how we can develop those services to be able to deliver what's best for the whole system response. And so not just about what's best for Tricura, not just about what's best for the local authority, but how the whole system response is required so that we can look after the maximum amount of clients in the current circumstance. Excuse me a minute, my computer screen's just frozen for a second. I think the light's working at this time of night. Now, one of the things that other areas we're looking at is our reablement service. So again, as I mentioned, we've got the Dorset reablement service that came out of Dorset County Council, the Bournemouth reablement service that came out of Bournemouth Borough Council, and at the moment there was also a separate reablement service in Poole, which is not transferred over to Tricuro when we started. Now, we are looking at the moment and we're bringing together those two, the Dorset and Bournemouth services, as to one whole reablement service across the county. Obviously, this provides us with efficiencies, both operationally and financially. We're implementing a new system into there at the moment, so a new planning system to be able to make sure, again, that there's more efficiencies found within that service delivery to maximise the staffing hours available, to deliver greater numbers of reablement hours, to help support getting more people out of hospital, and also looking at how ways potentially we can prevent people from going back into hospital at the first place, and supporting the wider disability care market to make sure that those people are moved on to the right and appropriate care needs in the best condition. This is obviously something that's just starting now, trying to bring these two together, but has already got some, successful, and we're just making the best of our staffing group. Now, that brings me on to one other thing. We talk about how our efficient use of resources are in the company. So from a financial perspective, when the company was set up, that obviously we were pooling services from 3 different local authorities, obviously, which have now become 2. When we had a whole number of staff on different terms and conditions with different pay rates and all those things, and we had to therefore make a mark of what Tricuro's rates and conditions were. Now, by doing so, whilst obviously if the staff members have their should be protected rights, it also meant that we were able to pick probably one of the most progressive rates that we could for new members of staff, and by doing so we've managed to probably save considerable amount of funds as the company has developed and recruited new staff. This has particularly been successful for the BCP area, and I've made significant financial savings year on year, thus helping relieve pressure on your own budgets. And this means that we therefore do not have to call to the shareholders to keep the same volume up to having increased costs, or such significant increased costs. We've also looked at each service individually each year and developed programs in conjunction with the commissioners. So we've looked at whether we restructure certain services or whether the service delivery is appropriate for the needs of today. And I've made some adjustments during the time there, making sure that we find financial efficiencies within that process. And we've done that year on year. And I would say, obviously, I wouldn't want to put a figure on it right at the moment, but there's been significant savings across the company for both local authorities by bringing Tricuro together. And again, as we move into the next stage of this transformation program, Whilst the transformation programme is not a financial savings programme, obviously the need for finding efficiencies and savings, given the current economic climate for local authorities across the country, it plays a key role in that, and making sure that everything we do is done with an eye on efficiency and savings as well, as producing the right delivery model for clients. Now, in that, one of the key areas that we're looking at is the modernisation of day services. So day services, as a tradition of being a buildings-based service, and now over the last few years anyway, Tricura has been about how it can change that perception within Dorset and BCP area to make sure that those clients there are getting the appropriate service they need, and it might not be the service that they're currently receiving. Now, some of this could be looking at how individual service funds might be looked at and worked with, how direct payments are looked at and worked with, what kind of service offer is available. Now, through the COVID crisis, we've actually presented us, pushed us into a situation as such that has allowed us to explore and develop things faster than we would have otherwise wanted to do. So again, looking at the technological developments that are out there, we've been able to potential ways of offering services that don't require people to come into buildings in the same way. We're also looking at the building stock that are being used to make sure that the most appropriate buildings are used for the right clients, and about whether the numbers of buildings that we have are those that are required. We have managed to go out and actually, during the COVID crisis, we have to have a different perspective on each individual client. So we would review each client as they were coming to visit us, and about what was the best way of meeting their needs with our available methods. So obviously not everybody can come into a building service at the time, so we would look at whether we wanted to make sure that those people were visited, as which some of them weren't, and therefore we could divert our staffing through obviously our ability to send staff out and on the enablement networks has given us the skill set to be able to do that. So again, using some of those day service staff to go and actually visit some of the most vulnerable. We've also kept up making sure that we've had some of the less vulnerable, as to say, making sure we have regular contact with them through phone calls, through video calls, by using different social media platforms that we can use to make sure that people are actually contacting with each other at the same time, and getting those social interactions that are so valuable to them. And then those with the most severe needs, as the situation developed, we were able to make some of the buildings capable for delivering those care in a socially distanced way for those with the most severe needs. Certainly some of those people with dementia is one of the areas that were strongly required, and it's not just about obviously care for the individuals, it's also about care or respite as well, which became quite a significant issue, I think, during that first stage of lockdown for this country. So I think we've responded well in looking at how we can deliver those different services in different areas. Excuse me, I'm just going to scroll down the report. So if you get to the financial bit, anybody who reads the report, what I started off by putting here for you was a quick overview of how the company was started as the point that LGR took place. So what the services, value of the services transferred in from the 3 local authorities into BCP. So you can see that, and then any changes that were taking place in year. You can see the value of Fairways Care Home that came in. And you can also see, therefore, what the total and the contract adjustments are. As Phil mentioned, it's just under 18.8 million at this point. There are potentially further changes for next year. Obviously, things like the government announcing a pay freeze for public sector workers means that actually it's not going to be significant changes financially. And then I've got for financial results for the year previous. So you can see that Tricura last year made a post-tax profit of 556,000. Now, in one regard, that's really positive, because obviously in significant challenges that we face, any profit is very important and can be potentially reinvested in supporting the local authorities one way or another. But also it's also a good reminder that as a percentage, there's a very small percentage of the overall of Tricura, and it shows how we're trying to keep everything as efficient and as economical as possible. Our overall revenue was 42.3 million, and you can see there's a 5% growth on that. Now, some of that, a lot of that was down to having new services brought into there, but we've also opened up Tricuro to private income. So one of the key things about when the company was originally set up was to look at private income from outside of the local authority contracts. Now, there are different ways of doing that, one of which would be to invest significantly into a new service or a new building or new centre or something on those regards. But that requires significant investment, and that's not really within Tricuro's gift at the moment. So what Tricuro started to do is look at how it could use its stock as best to support the overall financial position of Tricuro and therefore both local authorities. So we looked at particularly within day services, where the building capacity in a lot of our services was in excess of the clients and the staff group we had available. So that immediately meant a lot of our overheads would be considered sunk costs. So we could potentially bring in more private clients and therefore just with a flexible staffing model, we're able to deliver that at quite a low cost, therefore delivering a very good return. Now that obviously only happens on the first percentage of people coming through the door, and therefore you make really good profit on those first few people, obviously, and then that whittles away as you get more and more people come in. But actually we managed to build ourselves up to over £1.8 million worth of private income that way, of which there was a really strong, high profit margin or high contribution margin, I'd rather say, on that to help support the company's finances. We've reached a sort of tipping point, I think, now where to increase that, there's a bit of organic growth left in that, but to increase that significantly further, we'd have to potentially look at investment or converting beds from, so one option of us going forward is whether we convert some local authority beds into private beds, depending on what the requirement of what's required by the local authority, the number of beds they actually need within the local market. But it does give us some flexibility to look at. You'll see also our retained earnings here is just under £2 million at the moment. Again, that sounds a very positive figure, but equally for a company of Tricuro's size with its turnover of over 42 million, that doesn't provide us with a huge amount of cash flow protection should we need it. But again, equally, the cash flow of the company is extremely strong. One of the benefits, obviously, I'm sure most of us know of the local authority, is that whilst there might be budget pressures, actually cash is usually quite a secure position for them to be in. So therefore, we're able to make sure that a lot of the time we're paid up front and we don't actually have a cash balance problem. But equally, those retained earnings figures, whilst they're reasonable, a lot of private companies our size would hope to see larger than that. I've talked you through the income generation. And then how we're managing this through the COVID crisis. I think might be a good point now to ask if there's any questions on those specific areas or whether I can expand on anything in particular by anyone.
Thank you, Steve, for that very comprehensive report there. Can I just ask members, I'm not going to be speaking on this, but can I just ask, in our recommendations, it's recommended members scrutinise the performance of the company, and secondly, identify any key areas for further consideration by the committee. So if you could bear that in mind as well as your questions. Thank you. So is that Councillor Wilson first? I think it is.
I think Councillor O'Neill got there just before me, but if he doesn't mind me going first, but it's up to him.
No, that's fine, as you're already on the show.
Okay. Thank you for that. It was a very comprehensive presentation and one that I really enjoyed. Chair, I've got a number of points I wanted to just ask about. Do you want me to take them all at once or individually?
Are you directing them at Steve or at Phil? I think how they want to do it, whether they want to do one at a time or whether they want them all in one go.
Okay. Yeah, how would you like them? Would you like them all in one go or one at a time?
I think one at a time, because then we can probably work out who's best to answer the question, can't we, Phil?
Okay. So the first one was at 3.5 of the report. It said that there was a log of decisions which were made about lessons learned. I just wondered if you could give a little example of some of the lessons that were learned during the COVID period, you guys.
I suppose I was the method of delivering day services as well for one of those areas, and therefore the technological advances that we were looking at. So one of the things we did from there is realise that the need that any technological change that we looked at, any innovation that we looked at, the most important part of that, or there's two most important to that, is not the actual technology itself, it's actually how it impacts on the client and on the staff. And part of that process that we actually ended up bringing up a new digital transformation officer, and that person was actually a senior carer within the day services. Somebody who had previous history within technology, and somebody who was very passionate about technological advances themselves, but actually their primary function was a carer, and we're able to actually make sure that the lens that we were using when looking at that was coming from that aspect, particularly from the client, but also from the staff basis, so that we weren't implementing, or we weren't looking to implement, you know, the next best thing that always comes out, but actually what works and functions best.
Okay, thank you. Moving on to 5.2. So it says that we understand there is an over provision of residential care locally. I think that's true, but the public perception is that there's kind of an undersupply of care homes and residential stuff locally. So is there something that we as a not just Tricuro, but as a council can do in terms of taking the public on a journey with us and understanding what the local care needs are?
I think that's probably one for me to respond to. So we, in a very timely way, we've just commissioned an organisation with some support from the Local Government Association in the form of a small grant to undertake both a market position statement, which will be very clear about what the provision is across BCP. We've not had one as BCP. As the constituent authorities beforehand, we knew our own market, but what that will do is just tell us what we spend on in what areas across BCP. What we'll then going to do with the same organisation is to have them we've commissioned 2 commissioning strategies. The first one is around older people's care homes, which will use that information from that market position statement and then look at the demographic needs and what we're seeing from demand through things like COVID and just general needs in the population and a rising age, an age group, to determine what the future might look like for the next 5, 10 years and beyond. In what capacity do we need in the care home market? What kind of care do we need? Is it nursing? Is it dementia? Is it frail elderly residential care? And that will then inform what we need to commission and where we might want to invest, or where we need to reduce the amount of care that we have in particular areas. So Councillor Wilson, I think that's how we will we'll take the public on a journey with us on that. We'll engage with people, we'll understand, we'll be talking to people like Louise from Health Watch to get people's views on any strategy that comes about. And of course, we'll engage with the providers to make sure they're very clear on what we're doing. And the other strategy that we're going to get from them is an extra care housing strategy, because one of the things we have to look at is where can housing better meet needs when you've got care and support wrapped into it, as opposed to residential care. So it's not everybody should default between receiving care in their own home or receiving care in a care home. There are some middle grounds where your own home actually is a scheme that is set up to support you with 24-hour care and support on site, responding to a plan around your care and giving you a sense of community as well.
Cheers, thank you. So moving on to 8.2, there's a bit of a line I'm not very keen on that says, as with all provider organisations, we've experienced some safeguarding issues. It kind of implies or gives the implication that safeguarding issues are granted, which I don't think is a position that we should be starting from. But I was just wondering if you could give some examples of them and what you're doing to deal with them. I know in the following preceding paragraphs, you do mention some things that are being done to deal with, but what extra steps are being taken?
Sorry, I just came back in there. So I think what it's stating is that in this industry, in this market, that it is unavoidable that there will always be some safeguarding issues, potentially, however small they might be. Now that's always been the case with any provider, and it can be the most minute thing that you wouldn't necessarily, a lot of people wouldn't necessarily want to report or consider as safeguarding. But actually, if you're being a really good care provider, you should be picking up all of those, no matter how minor they might be, because that's a good way of actually really understanding what goes on within your care homes and your care environment. And I think that there's been a slight shift since Graham has come into the company, that we will go on that front. We will go to the nth degree, and we would rather over-report than under-report, because it's always a balance. As I say, there's always small things. So whether it is the slightest thing of whether somebody was how they were handled, how they were treated, how they were spoke to, there's so many different elements that can constitute safeguarding, that you actually want to make sure that we're capturing all of those and they're being monitored, and that way you can actually drive continual improvement in that area. So I think that's one of the big reasons why we're trying to highlight it here and make a point of it, because it's very easy to only report those that actually seem to have an outcome. So there can be lots of little safeguarding that don't apparently have an outcome, but of course they could do down the line if you don't start dealing with the very minor issues now.
Yeah, and that's really reassuring to hear, kind of thing, that taking it very seriously. And finally, so sorry to have taken the floor so long, just around 10.17, the digital home. Love it, really big fan of kind of helping people stay in their home and be independent. I think that's fantastic. Just wondering if you could talk a little bit more around the actual practicalities of it, and how much that is being used within the service.
Okay, so this is going to be a little bit hard one for me to field, and really I would love to have Mike with me to do so, because he's the driving force behind it. But again, it's about how to use those assistive technologies and how that they can actually improve the sort of the client's experience. So there's one thing that we're looking at the moment as a good example is I think they're called iTables. So they're like very large iPads, so sort of about 32-inch screen on them. They roll around on tables. So they have those that have the ability there for residents to actually be able to again communicate with the outside world, but also there are sort of apps and functions on them that can help with their daily life and give them a certain sense of satisfaction from their experience within the home. Like, they're not cheap, but you can get funding for them. But they're the kind of things that we're looking at about, is how it's basically improving the client experience, including their interaction within the home, with their interaction within the outside world as well, and with each other. So, and it's those kind of areas that we're looking to. It's quite I wouldn't say it's a new journey within the homes, but it's a rapidly accelerating one, is the best way to describe it. So there's little fires that we've had with ideas are now starting to to be pulled together.
Thank you. Much appreciated.
I wonder if I could just
Phil, did you want to come in there?
Yes, thanks, Chair. During COVID, when we had to close day services down because of the risks associated with our group gatherings, we provided, or Tricura provided, alternatives to people coming together in that building setting through a series of things. They either took them out into the community and did things because it was the summer and we could get out and about, but they also did things like Zoom exercise classes or Zoom crafts. So people were engaging remotely with the crafts teachers that are within some of the day services, and actually doing things online over the internet. And it was amazing. And unfortunately, we haven't really had the time tonight, but there's a great little video, which it might be worth, Steve, being circulated to members, that shows that interaction, and it's got feedback from people themselves and their carers, their families, about what a difference it's made in terms of that engagement and not losing the ability to interact with others outside of their household. So I just think there's lots of things. Some of it's about more efficient working, others is just about engagement and really supporting people.
Thank you. Thank you, Phil. Councillor Wilson, have you finished your question? Yeah.
Yeah, that's me done. Thank you so much.
Yeah, thank you for all those. Yes. Councillor O'Neill, I think you're next.
Oh, thank you, Chair. Yeah, I have questions around the operating context and then 2 or 3 questions on the numbers. But I would observe, I mean, it's the first time I've actually read any papers on your business, so apologies for that because I'm standing in for somebody tonight. But you certainly do have an interesting challenge. Certainly all the indications are there's a positive impact. And it's interesting that you're seeking to grow turnover by a sweating of the assets rather than acquisition, which financially at the moment probably makes excellent sense. You've touched on several areas. One of the things you did touch on was the need to raise standards, or that was seriously the influence. And when I say that, I'm talking about both assets and people, because really that is ultimately what will deliver the service and market your business to new potential. I'd be interested to learn how you see that evolving. The second part of the question you also touched on was the identification of new market opportunities and growth in current services. Now, obviously, in those areas, you'll be selective. So 2 questions there really. How are you targeting the areas with the most growth potential, and who is delivering that sales and marketing impetus, which will probably become even more challenging as costs push? And the last one is in terms of recruiting the right people into the service, those that have the ability and the passion for the sort of challenges your service faces. How do you aim to recruit the right people, develop them once they're into the service on both their job content and their competency? And importantly, how do you develop them where the passion and ability is there for promotion into the future? Because it does strike me in this area, promotion could be, and recognition through promotion could be a key motivator for those with the will. So they're the 3 operational context questions. I'll save the numbers to afterwards.
Okay, thank you, Councillor O'Neill. There's a lot to digest there. So I think one of the key things that I can respond to is actually when you talk about assets.
Yeah.
So as a company with 1,500 members of staff, and our staffing cost makes up more than 80% of our total cost. Clearly, our biggest asset actually isn't our buildings. Our biggest asset is the workforce that we have. It's the people who work for us. Now, in that regard, one of the big things that we've been doing, or we've started doing very recently, is we're looking at what we call a new people strategy. So that is supposed to combine the entire suite of what we look at when we look at our staff and the journey for them. So that was, to start off with, that's about recruitment. Now, as we heard in the previous report with the NHS and CCG, that recruitment is potentially a big issue at the moment, and that's no different for the care market at all. So again, we're looking at what's the methods we use to recruit staff, what's the methods we use to induct staff, what's the challenges that we're facing there, what systems do we use to actually, technically process that as well. So it's kind of an all, reaching strategy that we're looking at the moment. One of the things that we want to do, and we were really trying to drive, but it's bigger than the company, to be fair, is actually making sure that working in the care sector isn't seen how it has been seen in the past, that it is not just a job, that it is a career with prospects.
Absolutely.
We can highlight, obviously, actually there's significantly good earnings for care, residential home managers, for senior management within lots of care companies, and even some of the middle management, some of those sort of middle layer roles. There are still very good careers there. So it's about helping to take people on that pathway between, you can come into this company maybe as an apprentice, or maybe just as a care worker to start off with. But if you wish to take the opportunities that are presented to you, you can actually take yourself into a long-standing career with a good, good financial income for you and your family. What's then important for us is to be able to back that up with all the opportunities that then person would need when coming in, the training that they would need, the support that they need. So it's kind of looking at all of those different aspects. So again, looking at our training opportunities and our development. One of the things that's happened and actually been really helpful out of the local authorities is when we first set up as the company, our training was actually delivered by the local authorities as they were before. So it was a straightforward, they held the budget, we sort of bought into their training plans. And whilst that was a nice, safe and secure way of transferring over, it didn't necessarily mean that we got the most appropriate training that we could get for our staff group. So actually we've worked through, over the time to transfer those budgets in centrally, bring the staff in who look at the training plan, so we can then develop it and make it more appropriate and more specific to our Tricuro staff members, and that's starting to be really positive. So we've now got a huge suite of training opportunities, and then for a small team dedicated to looking at where they should, who needs those and what the training they need. Not just the statutory training, but obviously expanding on that and development training. Now, obviously, again, during COVID, we've had to then look at how we actually do to deliver that, because a lot of face-to-face trainings had to be cancelled. But that in itself has provided greater opportunities by looking at online providers and online methods to be able to do that, which in itself actually finds efficiencies. It reduces the amount of time that people actually spend away from their, I suppose, their metaphorical desk. And that's been a real positive. But that's one of the key things with this people strategy is looking at how we recruit, how we market ourselves as a company, and therefore take people on that journey and develop them. We've got a significant number of people within the company who are potentially, for the want of a better phrase, they're overqualified for their post. So a large number of our seniors who are the sort of, we have managers, deputies, and then seniors, and a large number of our seniors are actually qualified to the manager level. So we've got a good pool of staff available to draw on when we need to, whether it's short-term cover or long-term cover. And it's making sure we continue with that mindset that we offer the training opportunities for people. And it's one of those things that we've always said, if somebody leaves you for a better job, sometimes you've actually done, that means you've done a good job because you've got them into a position that they're capable of doing so. And that's what we kind of rather be in a position of having more people. So we're not just helping ourselves, but we're helping the wider market. It's one of the reasons why Tricuro was set up, was to have a foothold in the care market and to be able to help influence it. So again, the more staff that we have coming through our doors who are trained and skilled, the better it, whether they end up staying with Tricuro or not, but the better it actually helps support the wider social care market. Now, as for talking about buildings and those asset base, the difficulty we have is that Tricuro does not own the buildings. We have some that are leased, but most of the time we are merely tenants on the buildings.
Right.
So we have little opportunity in developing those buildings themselves without obviously going back and talking to the relevant local authority about how they wish to see or use their stock. So that becomes quite a difficult conversation with us. So that's again goes back to those commissioning strategies about what they need in what areas. We talked about the potential over provision of residential homes. Well, and again, and Phil mentioned about extra care. Well, obviously, the over provision doesn't just necessarily mean we've got more beds than we need that are currently occupied, but it also means that potentially we've got too many people in that provision where they could be better served with a different provision. So you have to look at that in the round is how you then develop those services in the future, and then that all comes part of how you look at your building stock. I'm trying to think how far have I covered in your question?
Yeah, the other one was the as you get cost pressure going forward, because there's a number of demands on not just income but profitability. You've got a hell of a challenge, because you can reduce costs and you can increase prices where possible, but growth does appear to be quite important for further income and profitability. And I was just wondering how you intend to perhaps more aggressively market to those opportunities that offer good margin returns.
I think that in terms of private, obviously there's different sorts of clients that we can look at that are outside of the local authority context, so outside of the block contracts we hold. So you might have the individual private client. So part of that might be looking at, say, development of the ISF, so the individual service funds. Right. Now that's a different market for us in a way. Whilst the care side of it, we deliver, and that's something that those potentially clients that we already have would still purchase from us. There's an element of actually managing their fund as a whole and then integrating within the wider care market as to how what other care providers they want. So they don't necessarily use Tricuro solely, they use a suite of care providers, and Tricuro might just be one of them. But if they've got an individual service line, there's an opportunity presented there that we actually might be able to become their individual service manager while still providing some of their services as well. So that's developing and looking at developing a different skill set within some of our staff to be able to deliver that. So there's opportunities there, definitely, and that's certainly the use of ISFs is something that I certainly Dorset are definitely keen to be using on, and I know Bournemouth and BCP are looking at. And nationally, there is definitely a drive for how we can use how they can be used more, because they actually help present individuality and choice to the client. So that's one area we can look at. Again, the other bit is actually how we mentioned about the assistive technology and about how, and actually through the COVID situation, how we've been able to meet the needs of some of our clients in a different way. And that presents opportunities to actually reach out to further clients without actually having to increase the staffing costs in the same way. It's more about linking and connecting the community and providing the facilities for them to do that. So again, whilst the margins on those individually might not be so good, there's the opportunity to grow and look and pull in more clients that way. So they might have a much smaller connection with the company, but those each individual connection provides greater income for us. So it's looking at things like that, I think, is the way that we can potentially achieve that.
Okay, just a couple of questions, Steve, and that's most reassuring. So thanks for that. On the numbers, I was sent some numbers. I'm not sure whether they're derivative of income or turnover, might be the same thing, or costs, but the Dorset numbers showed in 2018-19 a sum of 27 million round numbers.
Yeah.
24 million, which is a minus 12.5% reduction. And BCP went from 9 million to 19 million, 111% increase.
Yeah.
Can you put some clarity on that for me?
Okay, so this is all about the local government reorganisation.
Right.
So obviously local government reorganisation, you obviously had Dorset County Council, Bournemouth Borough Council and Poole Borough Council. So when local government took place, all of the Bournemouth council services, the 9.9 million, all of the Poole services, which are about 2 million, and then the Christchurch element of the DCC services, so 5.6 million. Those three areas came together to create the BCP total. Again, the table that I've put down on page 12, at the top of page 12, details that transition hopefully quite clearly. So you can see that there's a column for DCC, one for Bournemouth, one for Poole, and then one for Dorset Council and BCP. So you can see the pluses and minuses, how it pulls across to the pound. And does that answer your question?
Yeah, no, thank you. Yeah, no, it's an interesting summation. So thank you for that. You've certainly got a lot going on, some big challenges. I mean, with a net return of 1.3% and a need to satisfy shareholders and invest in assets, a challenge. And I guess the three challenges really are the growth in the assets, the improvement in the assets, the growth in the turnover, and I guess the ongoing retention and quality of staff. A lot of demands on a slim pot. So
yes, certainly. And one of the challenges we always face is the fact that we are a local authority trading company, but that also means we're an arm's length trading company.
Yeah.
So we have to balance the need of the company as it stands as a limited entity and the requirement to make profit, also with the needs of the two local authorities who are also shareholders as well as contractors and commissioners, to make sure that we provide financial value and efficiency for them. So that's one of the reasons why you're unlikely to see us ever making a stonking great profit unless we have opened up a private market somewhere. And we do keep our eye on those opportunities. There was one that came up a couple of years ago, but it carried too much risk with it. So again, and that's always going to be the potential issue. And also whether those opportunities sit within the county boundaries or whether they sit externally to those, because that again is always a potential with us, but it doesn't serve the purposes of the shareholder if we look outside of that, unless it is, has a really strong financial return. So there's always a lot of questions to be asked over any potential future investment or any potential future business opportunity.
Okay, thanks very much, Stu. That's very
No, that's right.
Very
Thank
good.
you.
Thank you.
Thank you. Councillor Butler, thank you for waiting. You've got a question for either Steve or Phil.
Right, yes, I've got to try and make them short because I know it's late. I'm just a bit concerned. I thought the report was very good from your interim managing director, very open and honest. But there are a few concerns because having come from a social service background in the past, I'm a bit concerned that it's talking about profit quite a bit of the time. Is any profit that is made by Tricuro ring-fenced for service delivery, or is it all going back to shareholders? That's my first question.
So the profit that the Tricuro has made within its opening, with nearly 5 years, and it's opening 4 years, is all sat in our general reserve. So the profits made by the company can only be paid back to the local authorities, the owners, by virtue of dividends. So it's post-tax profit. That's part of being that arm's length trading company. As it stands, because the profits that have been made have been quite small, and because our reserves aren't really big enough, in commercial terms, they wouldn't really be seen as big enough to support a company of our size. They currently have stayed within the company and just been held on to as part of our general reserve to be able to deal with any issues that might crop up.
Right. Only we were talking the other day about charges for social care day centres, which were going to be put up, and I feel that if you're sitting on quite a pile of money, why are these charges needed to be so high for people? Because you're talking about vulnerable people. That's my concern.
Okay, well, obviously the charging net that we have, if it's a difficult one, we're paid by a block contract from the two local authorities, so they pay a one lump sum for the individual services. Now, those charges that we're talking, are you talking about the actual charge for visiting the service, or are you talking the ancillary charges for things like whether it be for meals or for bathing or those?
The use of service, yeah, for
the actual use of service
a day, yeah.
So we don't actually put up the day rate specifically as a charge, as a unit charge, because by being paid by the block contract, what we do is during the budgeting phase is we look at what are the increased costs that we face, and then try and do specifically by service and by local authority, and also then take on board what's the mitigating factors. So we have several issues. The biggest issue in terms of cost for us every year is the pay award. So we get given, we are, all our staff are part of the Green Book terms and conditions, the same as all local authorities are. So we basically, we're committed to that, so that if the government decides, or as if the National Joint Council decides the pay award is, as this was year 2.75%, we have no way of obviously getting out of that. That is an additional cost pressure to the company. In the same regard, staff have other potential terms and conditions that increase the cost base. We have the cost of general inflation items, but equally we have things like staff turnover that take place that can reduce costs as well. So we detail all of those things out on a company-wide basis, and therefore present those as being the overall budget pressure for the year, which then that drives the overall contract price. So it's not necessarily specific to a unit charge for day services alone or for residential. It's all those things pulled together. Then when you potentially break it down, obviously it might show an increase in an individual service area, increased charge in individual service area rather than just by the company, but it is driven as a company as a whole. So we're not looking to put up charges at any point to increase people with those need. It's about the overall cost of the company to be able to make sure the company is actually servicing that, and that the contract is fair for both sides, both sides, and obviously we have to act as I say, an arm's length trading company to make sure that from the outset we are looking to make. We have to look to make a profit, otherwise we wouldn't be able to have our account signed off as a limited company.
Okay. The other thing is,
can I just say, I think Jan Thorgood wants to come in on this. So if Jan, if you could come in, thank you.
Yeah. I just wanted to
say that obviously the charging policy is set by the council as a whole, with some key principles that apply across services. One of those principles is that that the charges do reflect the cost of the service, and that is applied equitably across all services, whether they're provided by Tricura or not. So I just wanted to establish what we heard last time about the principles underlying the policy, and that it is a council policy.
Okay. Thank you, Jan. Sorry to Councillor Butler. Yes, because I was looking at specific perspective on our cost base, not answering obviously about the wider charging policy.
Okay. Yeah. Okay. Yeah, the other thing was looking at the buildings. I know in the report it said some buildings aren't fit for purpose, but again, trying to deal with people, I mean, trying to deal with people for care provision. If you're using the community, you need an awful lot more money and staff time for supporting somebody, maybe one-to-one or in small groups, rather than having a bigger group in a day setting. It's incredibly difficult to actually deliver care to lots of people when you put it out into the community. I mean, I know we have tried that before with lots of different, using charities and all sorts of facilities, but it is very difficult and also less cost effective. So I know we're going through the COVID period at the moment, but I feel we've got to look beyond that to what we're going to develop as a pattern for the future. So maybe updating service delivery, but still using some buildings, because a lot of people are socially isolated and they've got mental health problems. And if they're staying in their own home setting, or even just using digital technology, they're missing actual face-to-face contact with groups and their friends that they've had in the day centres. So that's one of my concerns, really, that if this report looks like it's heading towards closure of certain day centres or the running down of services for day centre attendees.
So okay, the first thing I'll say on that before I think.
Sorry, can I just come in?
Yeah, Phil, you come in first, Phil, because I think you'll say the same as me.
This is a bit wider than Tricura. I know the report talks about buildings not being probably fit for the future or fit for the purpose. I think that's partly as a response to COVID and the way now that we're having to look at how you cohort people or keep people socially distanced. And in buildings that just have one large room or possibly two rooms, it's really hard to keep people separate. So I think this is more about how do we work forward in a different world than we've been in for the past 10 or 15 years or longer. So alongside any changes to current provision would be the approach that we take where we've developed the strategy around that, but have engaged with people. So we haven't started that process or any process that says we will look to close any buildings. What we're saying is that if you look at how buildings are operating at the moment, it's going to be different in the future because of circumstances around us. And if buildings are 20, 30, 40 years old and haven't had a lot of investment, we may need to look at what investment might we need to make as a council in order to make them fit for the next 10, 15, 20 years. So I think it's the context around that probably isn't brought out in the report properly. It needs to link to commissioning strategies rather than just a statement that says we will move from X to Y. That's not the intent there.
No, thank you, Phil. I'd also just add to that obviously once LGR took place and you went from having, some buildings in Poole, some buildings in Bournemouth, and some buildings in Christchurch, suddenly all of those buildings all become part of the same pool, and that means that you can then look at are the right people attending the right service in the right property, necessarily the right location. It's also evidence that when it says potentially buildings aren't fit for purpose, that doesn't necessarily mean building closure. A good example is that Northbourne Connect being moved to Moordown. So it was a case of that particular building, which was in the local authority's asset pool, was not the best building, but they had another building that was an improvement, a significant improvement, and so that presented an opportunity there. So it's partly when you look at that as well. So that's quite a narrow statement. There's a lot more behind it than just thinking that it's potentially building shut. We're not looking at the moment at any buildings being enclosed at all. It's just opening up the question: are we using the right assets for the right people for the right purpose?
Okay. Because quite a few of the buildings can be used different parts, like the one in Highcliffe has got lots of little sections that can be used by different groups. You know, even if you were still social distancing. And of course, the one in Boscombe is quite a new centre anyway, and that's got different rooms as well. So hopefully, that was just a worry of mine that I feel we have got some good facilities across the whole conurbation. You know, that should really be kept for the community, you know, for everybody. Okay. Yeah.
Councillor Butler, can we just move on to a couple of others that need to speak, or have you finished your questions now?
Well, I think I had one more, but I'm not going to bother now.
Can I come back to you? Is that okay? Because I've got a couple here, Councillor Jones, Councillor Robson, that have been waiting for a little while.
Yeah.
Is that okay?
Yes. Okay. Thank you.
Okay. Thank you, Councillor Jones.
Thank you, Chair. 10.10 of the report states that one of Tricura's key challenges is having to use multiple systems to manage client and workforce which don't generally share data. Given the importance of data sharing in terms of security, efficiency and collaboration across service areas, what specific timeframe is in place to address this issue, and how will it be monitored at specific stages to ensure progress and as early as a resolution as possible?
Okay, so a good example of that is obviously when we transferred in, we had a payroll to two different payroll providers, being the local authorities themselves, and the same with sort of the IT equipment as well. So you had different for our different service sectors. Now that presents its challenges in itself by having, you know, two different pieces. So not all your staff are on the same system, so you don't all have the same reporting mechanisms. So you can't draw down what you're looking. You have to amalgamate two different systems at every point you're trying to produce any reports or look at any data. But obviously, there's a lot more behind that. One of the reasons why that's happened is because those staff that were delivering those services still, you know, were employed and live within each local authority. So you can't just lift a contract and take it away to somebody else without having an impact on the local authority and potentially that staff group that they employ. So it's not something that could have happened overnight and would have happened at the start of the company. But we are now looking, in collaboration with both Dorset and BCP, moving both our HR and our IT services to potentially having one system and one source for that, and being probably the one that's the most efficient in terms of our reporting mechanisms as well. So we don't have a set time frame on that yet, although we have a target date of the 1st of April for next financial year. There's a lot of hurdles to overcome for that. The things, you know, a project like this probably wants normally longer than 6 months, but actually all parties are involved in that are very keen to progress it as quick as possible. So as I say, we've got a target date of that for the 1st of April, something that I think is achievable, but challenging at the same time.
Okay, thank you.
Thank you. Councillor Robson.
Yeah, thanks, Chair. Yeah, I've got a quick question just on lessons learnt. Really, it's just about your matrix and how you're dealing with the lessons learned, and who do we as 50% stakeholder have that's holding you to account on those lessons learned, so we're not learning the lessons again. Thanks.
So obviously there's two parts of in particular engagement, you know, officially, I suppose. One of the factors we have our executive shareholder group. So that's consisted of 5 members from Dorset and 5 elected members from BCP. We meet regularly. We meet every quarter to go through and scrutinise the company, presented with manager director's report, financial report, any specific reports that might be requested at the time. So there's an opportunity there to directly scrutinise the company's workings, and things like the lessons learned will always be put into the manager report. Risk registers, those kind of areas always get put in. So anything that needs, you know, either needs greater detail or there is something important lesson that's come out of those could be presented there. We also have a transformation board at the moment, which is done in collaboration with both local authorities, that's held monthly, where we bring in the commissioners from each side. We look at the future needs of the company and again how our progress along this pathway is going. So there's an opportunity there. But obviously that's only the official channels. The unofficial channels is that there are regular meetings through all different partners that we have. So we'll have regular meetings with the commissioners of both local authority. We'll have regular meetings with senior officers of both local authority. We'll also have whole system meetings that we're involved in on a weekly basis. So, you know, actually Graham chairs the whole system meeting every Wednesday morning. So it's with other care providers. So the lessons learned that we find can be shared. The lessons learned from other care providers can be shared with us. So that as a whole system, we're looking to respond greater, particularly throughout the COVID crisis at the moment.
Okay.
Does that answer your question, Ash?
Yeah, thanks. Yeah. Thank you.
Thank you. Councillor Farr, you have a question?
Yes, thank you, Chair. It's just a quick one linking back to previous question to do with the sort of the finances. Are there tax implications when Tricuro makes a profit? I was just sort of curious about that. Thank you.
Yes, all our profits obviously have to be subject to corporation tax. As a private limited company, the vehicle that was set up by the two local authorities, any profits that we make have to actually go through that normal process, and we have an external auditors in KPMG. They both scrutinise our accounts and they also help provide make sure our tax returns are compliant at the year end. So any dividends get paid out post tax.
Thank you.
Councillor Butler, did you want to come back with a further question?
Yes, can I just ask about the staff training? You're mentioning about training and support for staff, which is really good, which it's been done in the past as well, which has been really good. I don't know if you've looked at what the Dorset County Council used to do, but they used to have a great induction training and support for all their staff. And also they had a ladder of staff progression where you could work your way up through from basic level up through, depending on qualifications as well. Do you think you'd be using that within your setup?
Yes, that's a model that we have already, but actually we are redesigning at the moment. So we're currently, particularly the induction program, so we're redesigning our induction program from top to bottom at the moment, where we're actually going to have almost a 3-stage induction. So you not only do you take the individuals in when they start the company, and then the first thing you do is you give them a brief overview of what the company they've come into, and then you deliver all their basic training within that first stage. So you make sure all the mandatory stuff that people have to have, whether that's PPE training, whether that's lifting and handling training, all those kind of things, they get delivered straight away. And then you get onto a more of an elaborate sort of induction part. So whether they'll then actually get to have, so we'll actually have a finance training part of that. So even for care workers who come in, they'll actually be given a short presentation on finance, they'll be given a presentation on HR, they'll be given a presentation on the wider services, the history of the company. So they're kind of trying to get buy-in from them of where they're coming to join. And then they'll be have the next stage of the induction will be to look at their specific service they're going to join. So they'll actually have an induction in the individual service and the program they're after. And a part of that obviously is also, as you say, it will be presenting the pathways that are available to them and the training that might be available to them to move their career forward, depending on obviously which level they come in and what their desire is. And then we're building then our suite of training up so that it's available for people who do want to take that progression, and obviously through their supervision and their training plans, they'll have individual training plans for them as well. So that's an evolution of what's already in place, but it's kind of like we're trying to bolster that up to make sure that it's a stronger training offer and a stronger sort of management support offer as well. That's the best way to describe it.
I think that would be really good. Thank you.
Thank you. Has anybody else got any questions? I can't see any hands raised. No? Oh, Councillor Phillips.
I need to. Hi. On the back of Councillor O'Neill mentioning about care homes. I'm aware of a private care home recently closing, and I wondered if there was any interest for the BCP to inherit or work with the premises. So I can give details of that one, but I'm sad to think that the home is about to close. And it's central Bournemouth. That's the first one.
Yeah, so Councillor Phillips, thank you. We have a history of acquiring care home not too distant past. It'll all depend on the due diligence around whether the business case stacks up for that home and whether that home has the right layout, its physical attributes, its location is important, any covenants on it. So what are the things that would stop us doing something different with it? And then is it good value for money? And how will the council fund any such purchase? Where will its resources come from? So we don't discount. I think I probably know the home that you're talking about. I'm more than happy for you to email me directly with the name of it, and because we do know the market, we do know which homes, and we talk to providers who are thinking about getting out of the market, more about what support could we offer them to remain, but also then if they're adamant that they do wish to leave, is there some benefit to the council overall of working with them to consider purchase of that asset?
So they are leaving, as in the tenants that are there, sadly, but I wondered if there was something for the future for that's
exactly what I'm saying. They're making their decisions on what they no longer wish to work there, but we may want to consider it.
Okay, thank you, and the understanding is clear. Also, as the Mayor of Bournemouth and the President of the Chest Help, I support and safeguard the homeless. I don't know where this falls now for an answer. I'd like to ask, I know Councillor Allen, forgive me, Councillor Allen works closely, but as Nicola Green, Councillor Nicola, said that we have to be probing, and I'm wanting to probe that we are looking into the problems with the homeless, with the TB problems that they have, and the other COVID problems that may be underlying. Sorry, I didn't know how to word it. I've waited a long time to put that forward, so I don't know who can answer that one, please. So I'm looking for probing to the homeless in their health issues, the Chest Help, which I'm a president of, and care about TB and other issues. Sorry, it's quite big for me.
Can I just say, Councillor Phillips, I do believe work with the health with the homeless is on our forward plan. So that may be something to discuss when we come to that item on the agenda. But Jan, I believe you want to come in here.
Yes, I just wanted to thank you, Chairman. I just wanted to really emphasise what you said, that we have talked about this item being on the forward plan. So probably when we get to the forward plan, we could.
Please, thank you. And I really appreciate that because I'm very passionate. Thank you. Thank you. Thank you, Chair.
Yeah, thank you, Councillor Phillips. Thank you, Steve Pink and Phil Hornsby. If that isn't, no one got any other questions on there, can we move on to agenda item 10, portfolio holder updates, where I'd like to welcome Councillor Karen Rampton and Councillor Nicola Green to provide their portfolio holder updates. Can I start with Councillor Rampton, please? Karen.
Yeah, thank you, Chair. 9:20, so I shall keep this very brief unless there are any questions that people want to ask. So I'm really delighted to be here tonight. It does feel a bit weird that I'm in a different capacity. I'm on a steep learning curve so far on various boards, including Joint Public Health Board, Safeguarding, Learning Disability Partnership Board. And I'm delighted that Councillor Diana Butler on this committee is the Learning Disability Champion, and she'll also be attending those boards as well. Health and Wellbeing Board, which is actually this week, and as you just heard, the TriCuro ESG, that's another one. I have weekly briefings with the Corporate Director and the Directors for Services and Commissioning. Recently I did adult social care briefings. I did 2 of those to around 250 staff in total, and lot of interesting discussion about the Home First model, which you've heard about earlier this evening, and about staff wellbeing. And I spoke on behalf of all councillors when I assured staff that they are really valued and they're supported and they're appreciated by us all. And I think it's really important that we tell them and keep telling them, because they're going through a tough time. It's not been easy and everybody's absolutely working at their limits. We had the all member seminar for the People First Forum, and I think anybody who came along to that will agree that they did an amazing job. And then of course we adopted their Bill of Rights at the last council meeting. I just want to point out that it is their Bill of Rights. It's not our Bill of Rights. They composed it. They did it on their own with support years ago. They've updated it since, and it's theirs. And it was long overdue that came to us for adoption. I just want to mention the front door presentation, which I think some members of this committee attended. And that was a really, really good presentation. I found it incredibly helpful, and it talked a lot about our strengths-based approach to adult social care. Would really like to have that widened out to all elected members. Probably beginning of next year, I think would be a good time. And that kind of goes along with something else that Councillor Jane Kelly is working on in her role as lead member, which is ABCD. And for those who don't know about that, is asset-based community development. And you'll be hearing a lot more of that in the months to come. Hopefully a seminar, maybe February, March of next year, and we'll be exploring that a lot more. But it's the front door approach is really key to ABCD. Just finally, just like to mention that we now have champions, and there are quite a few in the health and social care area. So we have Councillor Lawrence Weir, who's mental health champion, and Councillor Diana Butler, as I say, is learning disability champion. Councillor Julie Bagwell is disability champion. Councillor Jackie Edwards, our chair, is the dementia champion, and Councillor Mark Howell is wellbeing. And so I'd like to sort of welcome those champions and hope that we can all work together. Hopefully you don't have any questions, because I've probably taken up enough time and you still have to hear from Councillor Green, but happy to answer any that you might have, Chair. Thank you.
I can't actually see any hands going up at the moment. Has anybody got any questions for Councillor Rampton with her whistle stop tour that she did? No? Okay, Councillor Nicola Green, thank you. Councillor Green, are you still there? I know with her video before. Have we got trouble with her audio now?
Chair, hi, it's Joe Tyler here. If you're happy for us to just take a few moments, we'll try and assist Councillor Green in case she is facing difficulties. So just try and call her back in and make sure her video and audio is working. Thank you.
Thank you. Members, as time is going on, do we want to move on to that and then come back to Councillor Green?
I'm here.
Oh, okay. Thank you, Councillor Green.
I am so sorry. You wouldn't believe how many plugs and wires I have pushed and pulled, and there's a horrible mess for me to clear up later. So I shall try and be quick. I suppose it's appropriate appropriate to finish this meeting in a sense where we started with an update from public health, and perhaps to give members like Councillor Rampton did a bit of a whistle-stop tour of my portfolio. When the administration changed, Councillor Mellor as leader was very keen that somebody should have a cross-cutting role for the council's COVID response, and I must have looked keen. The purpose is not for me clearly to take on every part of the response for COVID, but it is to make sure that there is a read across. So where services need to be mindful of what's happening elsewhere, that's what I'm trying to pull together. A bit like Councillor Rampton, it has been an immensely busy few weeks. I recently chaired the Joint Public Health Board, which, as you'll be aware, is a service with Dorset. And in contrast to the previous work that I've done with the Public Health Board, you will imagine where all our focus was spent during that meeting. It is a small team, but they have worked immensely hard servicing the needs of the population of the whole of the county through this very difficult time, and providing timely, accurate and incredibly granular data, which members have found immensely helpful. As Councillor Rampton mentioned again, on Wednesday I shall be chairing the Health and Wellbeing Board. A lot of time has been spent on our community response. I've reported on that elsewhere, so I won't go into it today, but I do think members of this board will be interested in the extraordinary response we've had from our volunteers, and we are truly grateful to them. I did give a very full presentation to the Overview and Scrutiny Board a couple of weeks ago on the more detail of the Council's response, and I have just sent out this evening one of the regular updates, which I've done my very best to keep coming for all members, about the services which will be stepped back up, which have necessarily been stepped down over the period of lockdown. In terms of communications, which has been really vital through this period, we've stood up the Local Outbreak Engagement Board, which is where the council's senior leaders integrate with the CCG. Mr Goodson, who was here earlier, is always there, and that ensures that there is a response across the public sector in terms of where we are with the COVID situation. We are very, very pleased to see numbers going down locally, of course. We have consistently been tracking about 10% below the national average since about the middle of September. But we're very pleased to see the quite significant decline. But as we know, we shouldn't get ahead of ourselves, and the last thing we would want to do is to jeopardise the gains which our population have made by extraordinary efforts from all our residents by not observing any rules which are currently in place. So happy to take any questions, Chairman, and also perhaps to reflect, now that you're in place, with the sort of update that members would find appropriate from me going forward for your future panels. Clearly our work is very much focused on the COVID response at the moment, but there are other things that happen, and a chunk of my portfolio, of course, is around education, and particularly special education, and there is an obvious link into this panel in the transition to adulthood for some of those particularly vulnerable young people.
Thank you, Councillor Green. Anybody got any questions? Oh, Councillor Green, I think you've been let off lightly there.
Well, my stint of 2 hours of questioning at the Overview and Scrutiny Board, so I'm a regular appearance at all Overview and Scrutiny. I shall be at Children's tomorrow, so appearing at an Overview and Scrutiny Board near you very soon. If anybody knows, has further questions for me, they always know where to find me.
Yes, thank you for that. Okay, moving on to our last item, our forward plan. Now, we've been asked to consider and comment on the forward plan. Now, looking at it, our meeting date on the 18th of January next year has 3 full items on there. The Home First programme, including an update on the Better Care Fund, a COVID-19 update, and a report on the suicide prevention plan. So I think we've probably got quite a lot of items for our next meeting for that. Has anybody got any comments on future agenda items? The only thing I was going to say was we do have a list of commissioned work on there. So I think perhaps this is something we need to look at maybe at our next meeting in January. I don't think it'd be a good idea giving anybody any commissioned work with Christmas and everything coming up and being busy still with this second wave of the pandemic. Councillor, I don't know who was first. Was it Councillor Wilson or Councillor Butler?
It was Councillor Butler, Chair.
Okay, Councillor Butler.
Thank you, Chair. Yeah, I was just going to say, could we bring the homeless item, which is number 11, to our March meeting, because that would come after the consultation on homelessness and rough sleeping, which is due to finish the 20th of January. So that might fit in quite well.
Yes, we'll speak to officers. Councillor Evans and myself, when we plan the agenda, we'll speak to the officers about that, but that sounds like a good idea. Yeah, thank you. Councillor Wilson.
Councillor Butler actually took my idea. I was going to suggest that we bring that forward as well to the March, because obviously I think the homelessness strategy will be in draft around that time, and I was thinking as well of potentially including the housing strategy, because obviously housing is very good quality housing is fundamental to health, so maybe linking that into kind of a bit of a housing one. But yeah, so happy to support Diane's idea. Thank you.
Anybody else got any comments to make? No. Oh, that's good. Or maybe not. Okay, then in that case, I shall bring tonight's meeting to a close. Thank you, everyone.